Good morning, everybody. It gives me great pleasure to welcome all of you. And I know many more have told me on the phone that they are coming, but obviously being Sunday morning, I think it's very gratifying to see people here. Of course, in the Indian context, people don't realize, unlike the Abrahamic systems where God took a day off, so whether it's a Friday or a Saturday or a Sunday, in our system, the gods never took a day off. So India never had a concept of a day off, This is a very new concept to us. I'm glad that we are going back to our traditions and working on a Sunday. It's for reasons beyond my control, but that's why I really appreciate our speakers, our dignitaries, all of you here. Now let me go very quick. My name is Shakti Sinha. I'm the director of the Teen Murti of the Nehru Memorial Museum and Library. I'm very grateful to our distinguished panelists here, Dr. Paul, who will be delivering the inaugural address, member Niti Ayog, formerly from Medical Institute, Dr. Shamika Ravi, very fine economist who has just been made a member of the Prime Minister's Economic Advisory Council, Ravi Dhingra, very experienced civil servant, used to be Secretary Interstate Council, Chief Secretary Himachal Pradesh, all of you here, Sujata Rao, who's been in the field of health, a complete tower of strength, in addition to holding official positions, competent and passionate, friends from Brazil, Canada, etc. The whole idea arose from the fact that one, of course, healthcare at the very basic is something fundamental to the growth of a human being. It's not just in cold terms of human capital that we talk about, but in terms of a growth of a human being, something an entitlement to. And India has been failing in this task miserably. For its level of per capita income, our indicators are quite shocking. The fact that Nepal's infant mortality rate now is, and MMR has made tremendous strides. Bangladesh we know already. The only reason our HDI shows up higher is our per capita income. And that is a real shame. It is a real shame. I will not go into why it is happening, but what really started the concern was, as a result of the collapse of public finance in India, the central government had stepped in, starting with electricity to begin with, setting up the NTPC, and then moving on to health and education and agriculture, setting up a very large number of central sector schemes and centrally sponsored schemes in various funding ratios to support the states. And when states started misusing the money for their ways and means, then we started creating societies, autonomous bodies to which money could be transferred directly by the government of India. To me, it was a subterfuge. It was a violation of the constitution principles, but I leave it aside. It was a good cause. Now, obviously, with time moving to where the untied money, while the total money going to the states will remain more or less the same, the untied amount from the Finance Commission has gone up by 10%, which is a very good thing in terms of federalism, in terms of the fact that the state should decide how they spend the money. And the formulas, especially the centrally sponsored schemes, and I remember being in the Andamans, we had a scheme for growing of pulses, where we distributed dal ka packet coated with fertilizer and pesticide. Farmers were smart, they knew they couldn't grow the dal. They would simply wash the dal of pesticide and insecticide and fertilizer and eat it. The fact that you cannot have a simple solution, one short solution which works in the country. Each state's problems are different, the context is important. But what I've bothered some of us was that in this transition from moving away from centrally sponsored schemes to untied money, the states who needed the most support were probably the states who would be least able to make the transition. And that was troubling. Transformation is always a difficult exercise. It's never easy, it's always messy. As Mao Zedong once said, that revolution is not a picnic, it's not a party, It'll always be messy. How do we navigate the mess? That's why we thought we'll get people from everywhere who could help us, and I'm glad that we could get the assistance in the beginning of the Interstate Council, through them the Forum of Federations Canada, whose representatives are present here. And then, of course, Brookings stepped in, and Shamika has been a very big source of strength in this whole exercise. And of course, all of us. So we just thought of creating this. More people, I said, will come in today. But what we do tomorrow afternoon onwards is also more important. We had a small brainstorming a few months ago, I think it was in June, to set the trend for this. Now, obviously, we have to build on it. And the point I wanted to only make is that, and I'll end with that, is that a health professional speaking to a health professional is good, important, but not good enough. And the reason I wanted, especially the Interstate Council, very involved, and I'm glad that the Niti Aayog is involved, is that when people outside the health system start talking about these issues and talking about it, that it really gains. Supposing the Interstate Council in its meetings, where chief ministers are present, pushes this point of health, it gains a salience which otherwise it would not gain. Because the health minister, the health secretary would always want more resources. But one, of course, resources are not the only thing. Of course, not that you don't need resources. Two is that systems are more important, and that is where the political executive backing from the top is very, very important. So this is a small effort in that direction. Let me not take more of your time, but invite Dr. Shamika Ravi from Bookings India, who's done this outstanding report a few months ago. Shamika, could you spend about 10, 12 minutes, and then I'll request Dr. Paul.
Sure. Thank you, Shakti. Good morning, everyone. There is always something exciting to do on a Sunday morning. I'm just going to set the stage by giving you a sense of how things are changing in India. So I'm going to put together, some numbers, some estimates to give you a general sense of the trend and why this effort is important. So overall, the story is actually a good one. It's positive. There are enough causes of concern, and we will dwell on them through the next day and a half. But we must recognize that India has witnessed significant growth over the last 25 years, and this has translated to better quality of life for citizens. Now, overall, with that high growth rate in India, we are seeing that India is getting more urban, it's getting more literate, it's getting less poor if you look at consumption patterns, monthly per capita consumption expenditure. People have access to sanitation in the form of latrines, which has always been a cause of concern. And the statistics I'm going to show to you is 2014. Since then, you know that there has been a complete escalation of this effort towards providing sanitation facilities for households, and in particular the rural areas. But the statistics even before 2014 was a positive one. There is more health insurance today available in India, public as well as private. And you will appreciate that all these trends that have happened over the last 25 years or so have deep implications as far as quality of health of individuals is concerned. So this is just to put some numbers to the statements I just made. India is getting less rural. This is always an underestimate because the definitions that Government of India employs in describing what neighborhoods are rural are old definitions. So if you look at new definitions, then there is a continuum of sorts between rural and urban, and India is far more urban than the government statistics denote. Access to latrines, in fact, 40% in 2014 said they do not have. This number has now gone down to single digits because of the Swachh Bharat Abhiyan efforts. Literacy rates have increased. Consumption patterns have overall shown a very positive trend. If you look at the number of people insured, this is really an underestimate again. And that is because if you look at institutional data, if you look at government data in terms of how much outreach has happened of insurance, then that number is above 35%. Okay? But if you ask the households themselves, which is what this is, the National Sample Survey, there is always an underestimate. And that is partly because of the concern that, health insurance, unlike other financial instruments like having a bank account or access to loan and so on, insurance is it's a fairly nuanced, sophisticated financial instrument. And if you are not contributing to it, then the probability that you are aware of whether you have it and what it means in terms of coverage is actually low. So one of the reasons why there is an underestimate from household surveys in terms of who has access to insurance, the numbers always look lower than in reality that is the case. Now, what is happening in terms of health seeking of households in India? 7% more households over 10 years have reported being sick. Now, this is a good thing. One is, and it's not an indication of them actually being sicker in terms of morbidities and ailments and disease burden. It is also that people seek more health care. They are more aware of their status, and seeking health care itself is a measure of, in some sense, empowerment and quality of life. 18% increase in sick urban households, 14% increase in sick females. So these are self-reported data from the national sample. The one big discrepancy, well, it's not a discrepancy, but one trend that we have to really pay heed to is the expanding, exploding role of IPD in terms of health burden. We see that there is a 9% increase in the OPD, but there is a 42% increase in IPD. One of the reasons is, of course, IPD was very low to begin with. So obviously, when you start with a low base, the growth is going to be much bigger. But this is quite significant. If you look at private versus public, and I'm setting the stage because all these things we are going to discuss over the sessions in the next outpatient department. So when there is just consulting versus actual hospitalization, and IPD is inpatient department. Sorry, this is something we have to be mindful of because we are not talking to health people alone. We are talking to a group, and that is the objective of this, so pardon me. 75% of OPD in India is exclusive private, okay? But there has been a decline. There has been a decline largely because of the government efforts. 55% of IPD is private. So the numbers are very large. Private sector in India is a predominant player in healthcare services. However, the trends are downwards in terms of government efforts are pushing people to seek more and more care from the public system, particularly in rural areas, particularly women. So this is just to put some numbers in terms of per household, what is the increase in the health burden from OPD and IPD? 13% increase in real OPD expenses per household and a 66% increase in real IPD expenses per household. So households in India are increasingly paying more and more for their hospitalization. However, there are large disparities, which is why the Interstate Council, which is why addressing these disparities across the country is very, very critical. The annual real out-of-pocket expenditure increased 24% per person in rural areas. In urban areas, this increased by 50%. So urban India is getting more hospitalized, paying much more for healthcare than rural India. If you look at within the rural areas, then this concentration of increased out-of-pocket, it is amongst the extreme poor. This is a cause of concern. This should be a policy priority because most of our public insurance programs were really catering to exactly that segment. But if we are seeing that they are having to spend more and more, and they are spending more and more, we need to think a little deeper about what targeting of these insurance schemes mean. In urban area, however, the increase is across all quintile groups. So if you look at the first set of rows, that's rural population, you will see the increase in the out-of-pocket health expenditure is predominantly amongst the extreme poor. But in urban India, the increase in expenditure runs across all the quintiles. Everybody in urban India is paying more for healthcare. In rural India, the burden is largely concentrated amongst the extreme poor. This is all NSS data. What about impoverishment? 7% of Indians become poor because of health expenses. This was the case in 2004. That number still remains the same as of 2014, which is 7%. Now, in some sense, we can say that it's stable. However, in absolute number, it tells you that more Indians are becoming poor because of healthcare expenditure, and we need to be cognizant of that. This is just to tell you how do they finance? Well, they essentially finance from their own savings and contributions from friends and relatives, etc. Now, this is a monitor I wanted to showcase because, India, we have a lot of data efforts. Maybe I'll just skip. There are a lot of data efforts within the government, but it's fragmented. So state governments are collecting some data, central government is collecting within central government, you have census collecting data, you have NSS collecting data, there is a lot of, and Ministry of Health collecting data. So we have a lot of data on health, but they are sitting in fragmented ways. There was an effort that we basically undertook about a year back towards defragmenting it, putting it on one platform accessible to everyone. So for those of you familiar with the financial markets, this is in some sense akin to the Bloomberg terminal for financial data. Of course, this is all free and public because that's the nature of research in what we do. But it's really real-time data. You have trackers, you can go to district by district, and you can track what is the status of infrastructure in your particular district. And it is because eventually we want to democratize healthcare. People have to know how bad their district is in order to demand better care, more service, more infrastructure. And this, after the Gorakhpur episode, there was a lot of hue and cry about the state of infrastructure, public infrastructure in the country. But Gorakhpur, if you note, is actually one of the better districts in Uttar Pradesh. So it's only when you start tracking districts do you realize how much variation and how, in reality, situation sometimes is much worse than what we are made to believe when we just read media. So this is telling you primary health centers, sub-centers, by the way, are the first point of contact of a citizen to public infrastructure in health. Sub-centers, you have one sub-center for 5,000 people. Primary health center is the next range where you have 30,000 people who have access to a PHC. This graph is showing how much variation there are across states. The red states, the orange states have less than 25% of what the requirements are. The dark blue are telling you they are close to 100% of what the requirements are. And I say requirements because we actually have very clear guidelines in the government for how much public infrastructure should be made available to citizens based on population. So the blue states are very close to those benchmarks. They actually provide that infrastructure. The red and orange states are far from that. So you see there are huge variations. Within states also, so while all of UP might be orange and therefore there is shortage in public infrastructure, there are pockets of well-being in terms of availability of infrastructure. So you have about 8-9 districts which actually have good primary health infrastructure. Access to care is not just having infrastructure, it is having infrastructure close by. And we will not talk about quality, hold that for a minute. Access meaning how far are these sub-centers in primary health. Now this data, by the way, is available with the census department. Census is telling us that village with access to sub-centers within 5 kilometers of India, you have many states, Odisha, Arunachal and so on, that have less than 40% villages in those states actually have a sub-center within 5 kilometers. Okay? You have to walk beyond 5 kilometers for your first point of contact with the government health infrastructure. This is in UP. Now, the government also has information on what is the nature of, we call it quality of infrastructure, but it's not quality of care, it's just quality of infrastructure. Meaning, do you have the requisite X-ray machines? Do you have the specialist doctors, the A&Ms? Do they have housing available, labor rooms, and so on and so forth? This we have available within the health ministry called Rural Health Statistics. And this is at a state level. This is not disaggregated at the district. But what you will see is even in a state like MP, which by the way has brought in a lot of progressive reforms in financial inclusion, agriculture, and so on, when it comes to healthcare, there is an 80% shortage of X-ray machines. There is a 64% shortage of specialist doctors. Now, quarters. Now, we are talking about healthcare being, we really have to put greater emphasis on healthcare at the local and regional level in order to plug these gaps, which we are aware of within the government because the data is there. It's about highlighting these shortcomings. Also 80% shortage of all specialists in Madhya Pradesh. This is just an example. You can go on the monitor and you can play around and get these numbers at your district level. But these are just overall disparities I wanted to showcase. The other way to look at large disparities are what are the disease burden, the causes of death or mortality. We have national, health policy. We think of healthcare at a national level, but there are incredible amounts of variation when you look at disease burdens, the causes of death across states. So all India, we know that cardiovascular ailments are the largest killers, followed by ill-defined, and I'll get to ill-defined in a minute, and respiratory. Ill-defined is telling you that the nature of these diseases are such, or the nature of this death is such, that we are not able to accurately diagnose it, or the data is very confusing. And that's a very large segment. So it's also telling you that autopsy, the way it is being conducted and tabulated, recorded, Or maybe the disease itself, we don't know what the cause of death is. It's ill-defined. It's telling you a little bit about the quality of care, but it's also telling you about quality of data efforts. All right? Look at Uttar Pradesh. Again, it largely follows similar pattern because cardiovascular ailments are large killer. But look at the second largest killer for women. It's diarrheal diseases. Now, diarrheal deaths being one of the largest killers, in today's day and age, it should not be acceptable to a growing economy where healthcare is. Diarrheal diseases can be very relatively easily fixed. Now, the sanitation drives will naturally have impacts. We don't have the numbers to show you, but the idea being that diarrheal diseases remain predominant killers in UP. In Uttarakhand, respiratory diseases. Now, Uttarakhand, one generally thinks mountain, hills are cleaner, nicer. But for women, indoor pollution remains a big killer. And you'll see that respiratory diseases are the largest killer for women. Kerala is cardiovascular, just like an all India average. The idea of showing this slide to you is that the disease burdens across the country are very different. We need specific policies at the state level to really target specific types of morbidities and diseases. This is the final slide I really want to sort of motivate you to think in terms of why we should have this discussion. Healthcare governance in India, we have been planning largely sitting in Delhi. And of course there are great intentions and everybody wants the same thing. We all want good quality healthcare for everyone at affordable rates. But this top-down approach must be strongly complemented by a bottoms-up approach. States need to have a say. Not just states, in fact, I would say local communities. Self-help groups in the south, particularly Andhra, Karnataka, etc., were formed, by the way, not for financial, they were formed for social reasons. Yet those platforms are right now being used exclusively for financial inclusion. Why can we not transplant health onto them? Why can we not use some of these existing community structures to have these discussions on healthcare? There are huge variations in state capacities too, just as, when we started and Shakti made that note, that governance, so we want to track performance and sort of incentivize firms to do well and so on, but it's exactly states where governance break down, where performance is going to be poorer, so we need to be mindful of this endogeneity of this problem. For instance, a chief medical officer in Kerala is a highly empowered entity within the administrative system. The chief medical officer sits at par with the district magistrate when it comes to several decision making. This is not the case in most of the northern states, where CMOs really have to look at the DM in order to help them run many of their own schemes. Again, we need to think about these administrative structures and empower medical officers at the local levels, including district levels. And that really is the overall motivation for this gathering. Thank you.
Thank you, Shamika. Thank you, Shamika, for giving us a broader picture before I request the Chief Guest to speak. Something just came to mind. One is that the recent Ujjwala scheme, which is the cylinders, gas cylinders, has been a tremendous, change, tremendous, should I say, mover of change. Indoor air pollution is 5 times more likely to kill you in India than outdoor air pollution. And yet, papers talk every day, the Supreme Court National Grid Tribunal is only worried about. I'm not saying you should not be worried about outdoor. That is happening in a massive way, hopefully, touch wood. The Swachh Bharat you rightly mentioned, the amount, but getting toilets is the first step, it's not the last step. And the reason I mention it is, I'll give you 2 specific cases. As part of my district training, I spent a year, 6 months in a village in Tamil Nadu, undivided Trichy district, a small village called Amur. In Amur, when I went there the first day, and after chatting with people outside the Panchayat office, I wanted to use the restroom. So I wanted to know where, what. So they showed me a restroom, nicely locked and clean, kept under lock and key. It was inaugurated in the late 50s by Mr. S.K. Dey, who was India's Minister for Community Development when the Panchayati Raj started in the 50s. So in this village, this toilet was there. Very nicely kept. They made it very clear. It's inaugurated by VIP. It's a caste thing. We don't let people use it. That's why it is still in existence. The second, in my own village, we have a small little toilet at home. But everybody's amazed. Why? And I'm talking about years ago, of course. So why do you do it inside? You should do it outside. It's much healthier being in the Nature के साथ रहो तो people say it's healthier for you to be defecating outside. So one is of course getting the filters in place. Other is very, very important is the transformation of the mind. It is the behavioral change. So whether we need Mr. Thaller's theories or others, I think it's all of the above. So with that, let me now request the chief guest, Dr. Vinod Paul. He's at the right place as a medical professional. He's transcending he's now in the field of policy. I think he'll be able to give us that. Over to you, sir.
Thank you, sir. Good morning, Mr. Sinha, Mr. Dhingra, Shamika, Madam Rao, Dr. Rao, colleagues, honored guests from Canada and Brazil. It's for me a privilege to be here in surroundings which are historic, awe-inspiring in many ways, and to talk and be a part of discussions on a very, very topical issue and a very urgent issue. At the heart of, I spoke to Shamika yesterday, I was at the node also, at the heart of this is how, to me, this seminar is all about how we can enhance participation of the states in achieving the health that we all as citizens aspire to. When I joined NITI not too long back, and I was taking some reviews with my team, and I said, hey, let's work for increasing the health budget of all the states, and how can we do it? You know, there was a pin drop silence, and they thought, what am I trying to say? Because all our advocacy often is targeted to Nirman Bhavan or the North Block or the PMO's office. I think we forget that there is a whole lot to be gained by engaging with states in a systematic way, understanding their context, their limitations, at the same time understanding and appreciating the full commitment they have for their own state citizens. And I think we need to crack it, and I was wondering during the course of my learning, and I started my learnings under the shadow of Dr. Madam Sujata Rao and colleagues. So I'm learning, and for me it's a learning exercise, I'm being honest here. Is, which fora to use to make this happen? Where do we go? Because, instead of targeting all our advocacy to one government, or let's say one set of decision makers, then we have 30 plus grounds to play, and we may succeed in 4 of them, 5 of them, 10 of them. So that's what, gives me a very sense of satisfaction that this broadly addresses that issue. And therefore, thank you very much for organizing, and thank you for having stalwarts in the room to deliberate upon. Now, let me begin, so 2 segments of my inputs at this stage, which should serve as a trigger for discussion more than anything else. See it from the mind of confused people who are trying to be helpful. They're part of the government, but they're looking at a big picture rather than just a ministry or a segment or a sector or a part of a sector. Now let me begin by saying what we have something on the table, sir, and that is that we have National Health Policy 2017, released only a few months ago by the Honorable Prime Minister. It went through a churning cycle which lasted over 2 years, and I think by and large we have not seen any major criticism against the NHP, which is actually a great fortune for me personally, because that's our starting point. There's no time for debate. Some things have been set, the broad direction has been set, and there's a broad consensus. It, by the way, also, in a very balanced way, nuances apart, talks about the role of the private sector vis-a-vis the public sector, role of the state governments, and so on and so on. It's quite comprehensive. Now, I draw a leaf from there to pull out 2 specifics or 3 specifics. One, this nation, as a part of that policy, is committed to raise the spending on health, government spending on health, from 1.15% to 2.25% by the year 2025. I am taking it as a given that it will happen. And it also means that every year we will work toward that, which means about 0.2% GDP increase in health budget overall to come from state and the nation or the union government together. So that's a given for me. And let's make use of it. It's on paper. It's released by the Honorable Prime Minister, approved by the Cabinet. And that's not a small amount of money, if you know the changes. It's been so static that even this money is great. We also commit in the policy that 65% or more shall be spent on primary health care. It's music. But we'll come to a reality check in a moment. But it's music because all of us within this room and outside speak for primary health care. We also broadly agree that primary health care is a business of the government rather than any other player. And if we commit that major resource will go to primary health care, it's an opportunity. And I'll come to primary care in a moment, a little more detail before we go to the fiscal and finance part. It also talks about a vision for universal health coverage, and it also talks about convergence and moving toward, eventually health as a right. But let me return to three themes that you triggered. Well, governance included, so three themes. I want to come back to the primary care first because we must know how to spend the money. In India, currently, our primary care centered at the sub-center, looking after a population of 5,000 to 8,000, is practically all about antenatal checkups, immunization, remote child health, now maybe home-based newborn care, malaria, and almost that's all. Hardly any public health action by way of action to look after the determinants of health and of course, a fragmented effort on sanitation, water, this, that. But that's all we have. In terms of primary health care proportion, we are probably meeting about 15% of the need at that level. Okay? So what is the missing part? The missing part is, are we looking after tuberculosis at that level in a significant way? The answer is plus minus. Have we started to look at hypertension detection, management, secondary prevention? No. Diabetes? No. Cervical cancer screening? No. Oral cancer screening? No. So everything of this nature then is picked up either at dialysis at the age of 50 or for that matter, fully expanded and spread cancer. What about old age? What about mental health, palliation, adolescent health? Weak efforts, if at all. So first point I wish to make here in this is that primary health care is a huge unmet need of this nation. So whatever mechanism we devise to put money on the table, we must make the good use of using that for the primary health care and create once and for all a primary health care that India always needed. And the Boer Committee in 1943, 646, envisaged, and somewhere down the line we did efforts. There's no question that we made efforts in our own way, but it didn't go the whole holistic way. Mohalla clinics in this city are an interesting example where you have a fusion of the kind of things people expect. Little diagnostic, therapies, drug, picks up the drug and gives. We have models to follow from Brazil, and so on. Now the National Health Policy envisages a comprehensive primary health care. We have a document which is fairly visionary. I see that document not one of those 30 documents which line the Almeras, but as the blueprint of India's future health system. I want us all to put our weight on that. I want us all to come out with that vision, translate that vision into reality. And what do we mean by that? We mean that at the same sub-center, we will now enhance our infrastructure and our capabilities to look after this unfinished agenda, beginning with NCDs and beginning with cancer and so on, but also launching a public health action in the area around us, which may also mean, by the way, efforts to prevent obesity in adolescents and adults, wearing helmets so that we don't die, alcohol, what can we do about pollution at that level. So the public health action has to be coupled with primary health care that we build tomorrow, and the hub of this will be known as Health and Wellness Center. 2 A&Ms, 1 mid-level provider, a nurse practitioner or an Ayush practitioner, but who knows what needs to be done and will be able to prescribe continuing treatment of diabetes let's say, decided at the CHC level, continuing, follow-up possible, TB, treatment started here, follow-up next to home, physiotherapy of an old age person in the community. That's the kind of vision. I don't want to go more into it. The point I'm making is the vision is out there. And a start has happened in that regard. What do we need? We need 150,000 such units in this country. And the budget speech this year, the Honorable Finance Minister committed that we will make 150,000 such units without, of course, telling how much money will be available downstream. And that's our business, to put pressure now. But at the same time, it is our responsibility to make things happen at that pace. Because if we do it over 20 years, the game is lost. Can we do it over a period of 4 to 5 years? If we can create something like 50 lakh houses every year, can we not build these? Can we not train 150,000 people in different? Well, India can do it if it decides to do it. And it has, the budgets are provided. It can be. So the point that I'm driving here is an opportunity enshrined in the policy, enshrined in the speech of the Honorable Finance Minister, and a guideline available. Let's join hands to build India's primary health care that India deserves on the lines of what we have in Thailand and Brazil. Not in principle very different from UK's version, actually, if you see, because you have a doctor and he does a certain thing, the functions will be the same, not very different. Coupled with massive public health action in all aspects, to prevent diseases, to have a clean environment, linking with Swachh movement and so on. So that's where part of the money should go. The second, very briefly, is this issue of universal health coverage vision. Just to, again, put where we are, because money for what? The money is for primary health care, and the money is for, at least, also for universal health coverage. The National Health Protection Scheme has been with the cabinet for almost a year, and it is not moving forward. Those of us who know a little more about this would attest to the fact that actually it's a very thin version of a universal health coverage scheme, if you call it that. It's only for below poverty line. It's an upgradation of the Rashtriya Swasthya Bima scheme from 30,000 to 100,000 and additionality for old people. It's not exciting. It includes secondary care, a little bit of tertiary care. The coverages are modest. It's not universal because it's only BPL. It's not exciting. To many of us, it is actually not, truly not exciting. Some state governments are doing better already. So whether this moves or it doesn't move, there is a need for us to envision a more ambitious, more relevant, more exciting, more equity-sensitive universal health coverage scheme. To me, the characteristics of this would be, A, it should include the non-BPL. We can collect money. When we were in the HLEG, high-level expert group on UHC, we were foolish to say, oh, it's all unorganized sector and we can't collect money, and we said, thank you, yours sincerely. I think that was maybe okay for those times. But today you have Jan Dhan accounts, you have other ways, you have Aadhaar. It is possible to collect social insurance of a modest kind, and some state governments are already doing it. We drafted one as co-chair of the Health Commission for Himachal Pradesh. The Honorable Chief Minister should have announced it, he didn't. Where we talked about 1 rupee per day from a family. So people are already thinking about it. It is possible today for the non-poor, in large numbers, to be able to put into a social health insurance kitty to be available for a universal health. What will it do? A, we will get into the habit of paying. Because the size of the cake that we need to be universal and to be satisfied is much more than any government eventually would be able to. We must put money from our side. In any case, we are paying that money as oops, as a nation in any. Can that be diverted? Can the healthy people look after the unhealthy, the young looking after the old? So I'm saying here and ending this part by saying, let's continue to think about more ambitious models of universal health coverage. We can talk about details, you trust model, this, that. But then what is the basic thing? To me, the one ingredient is that non-BPL should get involved. B, we should think about how this can be, they can pay a certain amount on a certain basis. It is possible. We can talk about it. It's possible. 3, eventually, how the package can look more exciting. Not 1 lakh, maybe 3 lakhs, maybe 500,000, 5 lakhs. Why not? Maybe incrementally. and so on. So that's one vision, which is a current vision for us to build on. And I think that's something which is so very important, and that debate must start. The last bit on this I want to say is the issue that you raised, Shamika, is about governance. I think it's at the heart of the problem. Madam wrote an article saying 7 health secretaries in 7 years. We could go on to the litany of problems that we have with health system governance. We have people who are anatomists who do the Director General of Health Services. We have a person who will come from a clinic and be in charge of national immunization program today. Yesterday, he or she was in a clinic, very modest, but doing a great job. Good person, but not competent for the position where you have them. Then there is a severe divide between the NHM functionaries, the IAS, MD NHM, and the DHS. NHM was a great thing to have happened at a certain point in time. Those who say it is failure, they are wrong. I think the glass is hell of a lot of full with the money that you got. With 0.4 to 0.5% of GDP spent via the NHM, look at our indicators. We have been able to achieve, 64% child mortality reduction, and the bend came in around 2010 as a result of NHM. We are going to talk about it. But the point is, we have decimated the capabilities of the directorates of health services. They don't even talk. They are so, they lost confidence. There is no continuity. This person comes, he takes 1 year to learn, and the next year is ready to go. Some of them are bright. Some of them made a difference. There are other issues, transfer policy, deployment. State of Himachal should have 130 primary health centers. They have 430 because you go and announce it. So what do? You put a board and you put a doctor, and the doctor is doing his multiple choice questions to appear in the PG exam. Whole lot of governance issues, and I think that should be on the table. Having said that, now let me move toward the fiscal part and the state part. This is how we should spend money, more health out of the money that we spend, more well-being and the public goods we get out of the money. And now we come into some of the issues which are more proximate to today's discussion. You'll hear a lot of data, but let me just begin by saying that I'm quoting from the National Health accounts. In 2013-14, per capita spending was 1,000, particularly for our friends from 1,042 rupees per capita, of which 2/3 came from the states. The starting point for today's seminar in a way. 2/3 of the government health spending comes from the state governments, 30 of them, 30 of our states. 1/3 comes from the central government. And to put this 1,000 rupees or 1,100 rupees or maybe now 1,200 into perspective, what do we spend on CGHS? What do you spend on me as AIMS? Something like 5,000 rupees per capita. So the citizen is 1,000, and we, the privileged, from the government, 5,000, 500, 5 times. And that's what it is all about, 1% GDP versus 5% GDP. If you give 5%, we are happy. Ma'am is happy, I'm happy, a lot of us are happy here. That's the gap. But that is just to make a point as to what kind of money are we talking about. So we're talking about 4,000 rupees per capita, 3,500 rupees per capita, 5,000 may be a luxury. But that's the gap that has to be bridged, and I hope part of that will be bridged there. So this is the one figure that you may like to keep. From the National Health Accounts, we know that curative care in terms of inpatient services spending by the government is 35%. Outpatient, government spending, where does it go? 35% of it goes into inpatient, 45% to outpatient, and preventive care we spend only 9.6%, a point to be noted. Preventive care, which is all about the pollution and things we talked about, is 9%. Well, you can say the size of the cake is small, so what do we do? Sure. But then please remember, when you prioritize with higher motives. You prioritize with things that give you best investment. Here we are, 9.6%. We spend about 10% on governance. The next data that might help us is the following. Out of the government current health spending, With Govind Raoji being here, I'm being churlish, actually. Apologies if I'm being inaccurate or anything, but this is straight from the National Health Accounts. Primary care, we spend 51% of the government spending goes to primary care, rightly so. Secondary, 23%, and tertiary, 13%. Okay? Let me repeat. Primary care, 50%, secondary about quarter, and about 13, 14% goes to tertiary care. Why this is important? Because if you're moving to 65% more for primary care, it is a movement, but then unless the size of the cake is big, it may not really mean huge amount of money. We should realize that. Because whatever we are spending, we're trying to spend on the primary care in a way, or preventive care 10% and so on. So keep this in mind. This is just a situational analysis, but good to know this. When you come to state governments, we can look at the state government's role in different ways. So one of the ways is, what do they spend as a proportion of their GSDP? Okay? It's highly variable. The states which spend more in terms of 2%, 3% are the small states. Actually, the small states, for one beautiful reason, the Lakshadweep and the Mizorams and not Tripura, but Goa, they always huge amount of money per capita, whichever way you see. But having made that point, typically we see about 0.7% of the GSDP being spent, around about that, okay? 0.7, which is just about 1% at the central, overall you hear it. Should this not be more? One of the questions I have in mind from the audience at some point to guide us, whether when we have put our expectation with the state, should it be proportion of the GSDP or should it be actual? I don't know which way goes better in terms of being rational and in terms of being effective in our negotiation. The second way to look at the spending is actually more straightforward, and if you are falling asleep, wake up because this is easy numbers. Bihar spends 2013-14, 247 rupees per capita. Bihar spending on health was rupees 247 only per capita. Delhi was spending 1,800, you can say. Tamil Nadu about 850, UP 456, huge way. West Bengal 500. So we are about 500 range, 4 to 500 by and large, but we could be as low as 247. We should keep that in mind. Sikkim spends 4,000. Himachal actually is one of the better ones, spends better. Okay, just to keep in mind variations, we try to understand. We are low, but where the need is maximum, we are further low, and that has to be corrected. We looked at what is happening to budgets, of health budgets, particularly in the wake of 14th Finance Commission allocating not 32% but 42% of the central tax collection. Has it made a change? It's not a very robust thing. Again, Govind Raoji, you can help us much better with this. But I'm just pointing it out. Two things. Whether when you increase the kitty direct to me, am I putting more on health? Am I, as a state of Haryana, putting more on health when I get more money? I want to see whether there are any clues, or actually I reduce it because the central government schemes are now becoming less. So there is a mixed pattern, but just to again put some numbers on the table, no judgment. Punjab between 14-15 and 15-16 moved from 4.4% budget allocation to health to 5.1%. It raised. Assam raised from 4.2% to 6.1%. Rajasthan decreased from 5.6% to 4.6%. Orissa from 4.9 to 4.6. Two things to note here, that some states did this way, others, most were static in terms of proportion, some actually decreased it. Also, the rough number that you can look at is about 4.8 or 5, let's say. 5% is a good number. The National Health Policy commits states to spend 8% of their budget. So that's the advocacy point. That takes us to then the action point. Can we make them to stand up to that commitment, spend 8%, because then the budget size increases, even if you don't do it at the expense of other sectors. At least that proportionate increase should happen toward 8% in a certain way, because we have to increase the size of the cake. There is no way. You heard what we are doing now, 1042 rupees. So this is one, that we are staying typically around 5%, and if our goal is to make 8, can we incrementally do it by 2015? Which means next year would the budget be higher for every state? And that's the one aspiration, the kind of thing that we should. look at. Another aspect for which Dr. Govind Raoji would be doing a talk late this afternoon, but I have the paper that you submitted to Niti, and it's very interesting. These central government allocations. When you look at central government allocations to states for health, I'm stealing the thunder, but allow me, sir, to do it. Bihar gets 129 crore from center, with the population size and the challenges, and Punjab gets 150. That's the point sir makes. What is the basis? UP, 220 million population, gets less than Punjab, 148. And I can go on. He'll tell you this in more detail. When he draws the curve, it's flat, not in terms of IMR or challenges on one axis and what you get. There's no relationship. It's random. Why should it be random? To me, this was, I couldn't believe. So you can see how many scribblings I have done to see it in 100 ways. So allocation is another part, because the GST, 50% will go to state. And one point that emerged, I don't want to lose thread, I might like to say that in the conclusion, but remember, 15th Finance Commission is coming. Should we say that within that, there could be specific allocations to health? Right now, just given a blank card. Or even now can be course corrected next year. Because next year is the second year of the NHP. We are already losing one more year, and by the time 15th Finance Commission will come. And can the correctives be made now, that when you get these extra monies, can we apportion, can we negotiate this? And Interstate Council has a role therefore, because these negotiations could take place there. Now, toward the end, let me just say a couple of things to wrap it up. One is this issue of capacity of states to be able to do things. Because the top is always fluid, you heard me say that, NHM and DHS. DHSs are there for 6 months to 1.5 year maximum, 2 years, just unstable. How can we build their capacity to build the new health systems of all levels? Health systems are about governance, about HR, the infrastructure, the financial management, service delivery, monitoring. How to put, new India cannot happen on an old health system of the country. New India's health system. Health has to be achieved on a new health system, a much better health system. Money is a crucial part indeed, but then we should know how to spend the money. So what are the ways in helping the state government? They typically will go to the junior officer or a junior consultant of UNICEF to write a PIP for NHM. It happens so very often. Not always, but yes, that's the level. We never see integrated nutrition and health plans together, which is the need which has been stated for so many years by our government. It doesn't happen because those capacities don't exist. How can we do that? That's in a way is the key. As we tell the state governments to spend more on health, they should spend on such mechanisms which enables them to take their own decisions better so that things are not dictated. One reason why people will justify we dictate is because you don't have the capacity to do it. So you ask people, how do we do IUTF or you don't do IUTF? Do we do a mixture recipe, or we can decide our own recipe? This has come because of that understanding. There is also a word around the fact, should health be a concurrent list? It should be on the concurrent list. I'm flagging this. I have no view on it, honestly, as Niti or as individual. We like to hear. So I hear two voices. The moment somebody says concurrent, but education is concurrent, it's equally bad. Then you say, no, you are taking away the federal structure because you want, Ministry of Health wants more power. But then education, do they have more power? I don't know. So I'm just raising this because this could enable more, and my specific reason to mention this is that when you use universal health coverage where the parameters will be set, then will there be 30 different flowers that will bloom? Or you need a little more tight, broad guidelines to flow to be able to deliver it better? I don't know. I don't have the answer. Okay, to sum up, therefore, on behalf of the Niti, tell us how we can engage with states to be able to have greater amount of resources being spent on the health sector. How can we do it? Proportion of the budget, actual amount, How can we do that? What are the ways through which we can do the right level of high level advocacy, both here and in each state? Those things don't exist. Where is the movement in Haryana to have a greater spending on health? It's random, one newspaper article in 3 months or 13 months. How can we engage with the states? It's not known. They just increase budget every year by a certain amount of money. That's how it happens. पिछली बार 1600 दिया था, अरे इस बार 50 और, 100 और डाल दो, बड़े liberal हैं. So how can we do it? What should be the parameters on which you do it? Burden, state GDP, actuals, benchmarking around something, and so on. I don't know. Think about it. Can we use the 15th Finance Commission opportunity in a certain way? Think about it. Can we even now do the course correction? Let's think about it. Can we use the rural development money that goes straight to the panchayats as a part of the 14th Finance Commission transformation to be spent on health and wellness center, which will need, by the way, about 25,000 crore of rupees over 5 years, which means every year 10,000 crore, which means 25% more every year budget. That's inconceivable. Doesn't happen. Hasn't happened. So how do I collect money for primary health center that we want to build if we say we want to build them in the next 5 years, no point in doing them in 20 years. India needs that today. Our NCD battle can only be won through primary health care, detection, so that I don't land up with dialysis at 52 years. Let me be detected at 32 years of age. So that's the point. Can the allocations be made rationally? But above all, can we move fast? Because if all this has to happen, if I believe the national health policy, which means a rise by about just less than 0.2% of GDP every year to even match that 10-year 1.5 change to 225, it would mean that there has to be an increase in the budget of the union government for health by 20 to 25%, by about 10,000 crore. And that's to be done in February. Where is the advocacy there? Where are those great ideas that I can go to the Honorable Prime Minister and the FM? How empower us how to make a greater case? How can we all collectively make a case? It would also mean that every state will have 20 to 25% increase in state budgets if we have to go. That's again tomorrow. Which mechanisms? I don't want to lose this year. Next year is election year after that. So that's the urgency of talking about these things, and I hope this seminar would be of help in this direction in terms of the specifics, which are right there under our very nose. Because if you don't change tomorrow, then the next tomorrow will come after 2 years, knowing next year and the next year being politically very different historic points. Thank you very much for the opportunity. God bless you.
Thank you, Dr. Paul. Lots of room for thought, universal coverage, greater budgets, governance, obviously, copay, obviously. Lots and lots, I think, food for thought, and very specific pointers on where we should be looking at. That we now request Mr. Ravi Dhingra.
Thank you. I think this is a most timely initiative of the institutions, NMML, Brookings, Interstate Council, and the forum to get together and discuss the critical issues of public health and health financing in a federal setting. The last words Dr. Paul had mentioned, and I think which is most critical, especially for health, is how do we move fast. Now that I'm reminded of a story in The Economist some years ago, and it said, India moving slow. Now, that is the description, and we are often described as the lumbering elephant, and this is what we have to focus on if we can change things and turn around things, especially in the health sector. You mentioned about primary health. I worked extensively in the field, in the hilly regions of the state of Himachal. And I will tell you the problem of the primary health centers. There is no disagreement that the health infrastructure should be strengthened at the primary level. But we have two problems with this. Number one is getting doctors, number one, to stay there in these centers and not move out. And they should complete their tenures. If you talk to the doctors, they say we have spent a lot of money on our education in private medical colleges and we need to pay back. So there is no systematic solution to the issue. And if you get unwilling people to serve in remote areas or in difficult areas, you are not going to achieve very much at the end of the day. The other problem in the field has been the policy of centralized procurement of medicines and equipment. Now what happens is, it is not done professionally and there's a mismatch of logistics. So the doctors in the field tell our DMs, the commissioners, that this should be decentralized. But it has been considered, but it has not been found feasible on account of various reasons. So this is an operational problem where the equipment and the medicines don't reach in time or they are absent. Everybody agrees that we should have an effective and vigorous system. Now, in a federal country, at least in India, 90% of the action of implementation is at the state level. We have made policies of National Health 2017, but implementation is what is the crux of the situation. And there are huge variations across states. So unless the administrative systems move along with the objectives, you'll have huge variations in health outcomes. So the better administered states will have better outcomes. The other states where you said because of reasons of lack of allocation of funds from the center, there are difficulties. But at the same time, nothing prevents the state from increasing allocations to health sector. If a norm is fixed of 5%, there is no reason why the objective should not be met. In fact, there's need for a forum, and you mentioned interstate council, where these things could be negotiated, that all states agree on a minimum benchmark percentage. Now that could be one recommendation. The other is that the forum has been involved in several countries. We have worked in partnership with institutions in Switzerland, Germany, Spain, Mexico, Brazil, Nigeria, South Africa, and India. And it is our endeavor to continue our association with private partners and government institutions. And I'm happy to say that the forum would be happy to have targeted workshops in different states of this country and involve and invite foreign experts to discuss issues with the representatives and all other stakeholders. I once again thank Shakti NML to have taken this initiative to get us all together here, and we hope and look forward to the deliberations and the conclusions that follow. Thank you.
We'll take a 15-minute break, tea coffee break. It's been served downstairs outside the auditorium. And the first session, 11:30, 11:35, is on technology, algorithm, and data analytics. We thought that's a serious issue, improving access and quality of care.
Can I ask one question? I have one question for Dr. Paul.
We're running short. I would like to start the session because we are 15 minutes late and we need to finish by 1 o'clock. Welcome to you all to this session on technology, um, algorithms, I don't know why that word came in, but algorithms and data. It's a very interesting set of issues that can be captured in the title. And I have a remarkable panel of 3 people who will give their presentations for 15 minutes each, and after that we'll throw it open for question answers. But before that, just a quick introduction on what is the importance. I mean, technology, as you know, is going to be the driver for the future. And so we have, I think Oman is going to tell you about how we collect data. So we have in the ministry about 5 sources of data where we get information and statistics. One is every 5 years. From 1995, we've been regularly every 5 years collecting information from, actually I should stop saying we. I'm not in the ministry, I'm a common citizen of India. Okay, so I don't hold a brief for the ministry, but I'm so used to being in the ministry, I keep saying we. So we are not we, they. Collect data from National Family Health Survey, which is a very extensive survey, over 100 and odd lakh families. That's 5 years, except for the last term when instead of 5 years, they took 10 years. So we have the latest NFHS. And then we have the SRS as a sample registration system that again RGI gives us every year on 3 critical indicators of infant mortality and CDR and so on, which again women will be expanding on. And then when I was secretary, we took a decision to get district level estimations. These are state level. And for the district level estimations for 3 years in the low performing states of India, that's UP and Bihar and Madhya Pradesh, Rajasthan, Chhattisgarh and so on, we had the RGI again to undertake household survey. That was the largest household surveys that were done in the world for 3 years continuously on a wide number of indicators, which is extremely valuable data over there, and help you to give you district level estimations on critical indicators. And then we have from the IIPS, which is a Government of India institution called the Indian Institute of Population Sciences. They conduct periodically something called the district level household surveys, which again give you very vital information on the current status of infrastructure and on information on key indicators. So the DLHS is again another very important source of giving you district level information. And then there is the program data that the ministry officials collect on the schemes that they are implementing. And the challenge really is how can we triangulate all this data to make the story and understand what is happening really at the district and the sub-district level. So, and I say technology is the key for the future because technology can really help disseminate information. It can help, at one level. At another level, it's most vital tool when you're talking about transfers of resources from center to state and state to panchayats, district and district to panchayats. The most effective way of tracking and monitoring could be use of technology, mass of data. And we did introduce maternal and child health tracking systems where the vision was to computerize, including cell phone numbers of all the 27 million pregnant women. So that was done, and that used to be tracked to see where is this woman going and what is happening, where does she deliver and so on. That's called the MCTC, computerized database. I don't think anywhere else in the world you will find such databases. And then at the patient level, again, there is a whole concept of portability of data and how do we use technology where anyone can go and get his treatment and get his drugs and so on. So that's again another area. And besides the use of cell phone for getting blood reports to the specialist, so it's a huge dynamic area. And I hope one of the speakers will reflect on use of technology for bridging geographical distances as well as getting better quality information from the field itself on a real-time basis. And the main gap, and this is to flag the issue for all of you, the main gap that is really stopping us from coming up with getting away from generalities and getting more down to earth specific implementable plans is our very weak data system on 2 factors. One is reliability and the frequency of this data that we collect. Huge questions on reliability, huge questions. There's a lot of fudging, and There are various reasons why that happens, but that's something that we need to be mindful on. And the second is, and much more important in my opinion, is the disease burden studies. We don't have, I mean, you know, everyone dies of heart attack, everyone. Finally, when the heart stops, you're dead. So that's not, cannot be listed as cardiac. And when you have disease burden estimations and you plan according to that, you're really putting your money in the wrong, you're barking up the wrong tree. And we don't have, except for cancer where there were some registries, but ICMR should really be given funding to get on with getting registries for cardiac and registry for all other, and get proper disease estimations. That's still not done. So we really don't have any reliable database, except Prabhat Jha's million death study, which was done in 2010, and even the estimations that he made based on the oral autopsies of those million deaths, the government is not really accepting fully. I mean, whenever it's convenient, they do, but they don't accept his data that 100,000 people die of malaria every year in India. We still report only 1,500 deaths. So, you know, it's not convenient for us. So this kind of thing is going on. But the point really that's being made is we need to have a much better system, a regular system of registries, and track the disease estimation. Without knowing what really is the burden of disease, I'm afraid it requires a lot of skills, a lot of capacities, a lot of money. Can you imagine that even a disease like TB, the last prevalence and incidence studies were done in 1956. We still don't have, we really don't know what the incidence of TB in India is. So it's that kind of a gap. And I think that's where the challenge is. So with these opening comments on this important topic, I would like to turn to Uman. I've known him for a long time. He's a long-standing health researcher, and now he's working with the Observer Research Foundation, a very high-powered foundation in Delhi. And so, you know, I have him right on my right side, which endeavors to, this research foundation endeavors to take health and nutrition to the policy high table and establish health and nutrition security as important components within the broader national security discourse. So an important pathway of achieving this will be through analyzing latest data sets and having health observatories and so on. That's the objective of the institution where Uman works, but he's a scholar from JNU, and now he's deeply involved with health research, and he's been looking at some data sets and so on. And so I would request him to start the discussion by giving a much greater in-depth analysis of what I've just said for 10, 15 minutes. Thank you.
Thank you, ma'am. And my sincere thanks to the organizers for giving me the opportunity to be part of this important conference and to listen to such inspiring experts. I'm not an expert on technology or algorithms. I am an end user who uses health information and who has concerns about quality, equity, and access. In the context of what the government is trying to achieve in the health sector, in the spirit of cooperative as well as competitive federalism through performance-based fiscal incentives, collection, analysis, and dissemination of health information becomes very important. I will try my best to give the broad picture and flag a few potential concerns for policy research. Everything now seems to be prefixed with revolution. There is a data revolution, there is an artificial intelligence revolution. Big names in the industry like IBM and Google are competing in cutting-edge AI applications in health, resembling the race between USA and USSR to put first person on the moon. I hope some of these are discussed in this session later. There are such applications closer home to. AIMS and ISI use cutting-edge analytics to reform the appointment system led by Dr. Kapoor and other colleagues. AIMS-like initiatives need to be replicated countrywide to ease the patient load as well as to improve quality of the hospital experience. India has actually covered some ground in terms of streamlining its public sector health information infrastructure. Currently, 676 out of the 700 Indian districts regularly report public facility level data to the National Health Management Information System. 97% of the health sub-centers, 94 PHCs, and 85% of community health centers submit regular health data. The quality of the HMIS has actually improved over time, but experts often say that some of the data is a reflection of what the health managers would want it to be rather than what the situation on the ground actually is. Many experts think that information technology hasn't permeated in the healthcare sector as much as it has in other sectors. India has not fully tapped into the potential that information technology offers to integrate the health information systems in the country. The National Health Policy 2017 has suggested that a National Digital Health Authority will be responsible for developing common standards, notifying them, and for ensuring that there is buy-in from stakeholders, including for the private sector, which now remains mostly outside the purview of the National Health Information System. Apart from the HMIS, India depends on surveys including NFHS, NSS, and the sample registration system for its health information needs in a limited sense. We have had DLHS and AHS which have been integrated into the NFHS system, and NFHS offers district level estimates every 3 years, which is a leap forward. But given the changing disease profile of the country, the reproductive and child health focus of NFHS can offer only a somewhat limited perspective. SRS-2 gives us many indicators only for the big states because of sample size limitations. Till this year, till 2017, India did not have state level estimates of causes of death, as ma'am pointed out. Irrespective of these data gaps, a broader question needs to be asked, as there are trade-offs involved. Is lack of technological innovation in data collection or cutting-edge analytics really a binding constraint for Indian health policy making? This needs to be discussed a bit. Primarily, what is the infrastructural base for broad basing and for democratizing such technological innovation? The latest data say that 25.6 sub-centers don't have electricity in India. 28.5% don't have regular running water. 10.5 sub-centers in India don't have a motorable approach road. For the low-performing states, which we focus on, where we want these innovations to improve access and quality, these proportions are going to be much higher. If you remember, sub-centers will be now turned into health and wellness centers, and these will be the hub around which the public healthcare delivery system will work, managing diseases, managing referrals, and taking the load off the tertiary and secondary institutions. So one question to ask is, apart from some urban centers, have we overcome the basic infrastructural bottlenecks? Are there factors that help us leapfrog such fundamental constraints? Added to this are the financial implications. There are pilots going on with mobile devices. However, just giving a small handheld device to each ASHA and Anganwadi worker, there are more than 2 million of them across the country. It can cost much more than what we currently spend on Rashtriya Swasthya Bima Yojana, the National Health Insurance Scheme. Unless such an initiative to improve HMIS is linked to other initiatives, to that of transforming the civil registration and vital statistics systems, for example, it may not be financially viable even. Currently, the way our governance system sees technology leaves much to be desired. That is an additional constraint. When the world is talking about a data revolution, we are often told that there are government offices where a computer is still used as a glorified typewriter. Data entry is done, a printout is taken, put in a folder which is safely kept in a room which can be rightly termed as a graveyard of information. And the digital file in the computer is promptly deleted as soon as possible. So the second issue is, do we use the numbers we already have optimally for decision making? For example, we know about a big gender gap in healthcare access, particularly in the tertiary sector. Analysis we conducted at ORF based on government data for the year 2013-14 showed that in terms of health insurance claims across the country, the number of claims paid to males is 70% of the overall number, and that to females is just 30%. The claim amounts paid to males is 72% of the overall amount, and that to females is 28%. The discrimination was more stark at the extremes of age. For example, for the age group of 70 and above, for every claim paid to a woman, more than 11 were paid to men. In the 0 to 5 years of age group, for every claim paid to a female, more than 4 were paid to males. Last year, gender bias in cardiovascular healthcare was brought out by a study conducted in Punjab, which found that 62% of the children treated in the tertiary hospital were boys and only 38 were girls. A couple of months back, Dr. Kapoor and other colleagues at AIMS published results of a large study which covered more than 23 million outpatient visits in 2016, excluding those in obstetrics and gynecology departments, which showed substantial gender gap in access to care in AIMS. Interestingly, both the hospital studies in 2 different cities had the exactly same male to female ratio of patients, 1.65, or 62 males per 38 females. Like in the case of the insurance study, in AIMS 2, the bias worsened with the extremes of age. All this analysis is based on government-owned data. That means the system knows about it. System always knew about it. But what have we done about this? I'm afraid we haven't done much. I will take another example of malaria, which ma'am had mentioned. Our official causes of death data shows that 1/3 of malarial deaths in India are from one state alone, Odisha. Malaria is a major cause of death in the state, with almost 9% of all deaths in the state caused by it. It is the 3rd biggest cause of death in Odisha. It is not just in Odisha. 7.7% of all deaths in India in the age group 5 to 14 is because of malaria. Yet our National Vector-Borne Disease Control Program reports under 80 deaths from the state of Odisha due to malaria. In fact, the SRS system, which is a sample-based system, probably captures substantially more number of deaths of malaria than the surveillance system that we have. I'm afraid we don't hear many policy discussions around this, around these preventable deaths of kids. It is not just lagging states like UP or Odisha. Even rich states with well-equipped institutions flounder while managing predictable disasters like dengue outbreaks, for example. An audit had shown that year after year, Delhi has been conducting intensive and very expensive media campaigns only after the peak dengue season has passed. The information that the system has in these cases is rendered worthless by the lack of use. Thirdly, are there sufficient incentives within the system for stakeholders to take up innovations? For example, what does EHR have to offer the doctor? In our already overcrowded tertiary hospitals, how can we ensure quality of information that EHR collects? We have yet to see governments leveraging the large government-supported health insurance schemes to get private healthcare delivery institutions to share data. EHR is not often presented as a tool for patient empowerment or democratization of the medical profession itself. Fourthly, does our health policy ecosystem support free flow of information between stakeholders? We see that flow of information between different arms of the central government itself is limited. There is intersectoral, interministerial, and interorganizational incoherence. For example, India strangely has 2 different targets for the same year for maternal mortality. Niti Aayog's 3-year action agenda seeks to reduce MMR to 120 by 2020. The National Health Policy, however, seeks to decrease the MMR to 100 by the same year. This gets reflected on the ground too, where information systems of different health, nutrition, and related programs do not talk to each other and end up overburdening the last mile workers. Also, the solutions often assume that design problems can be overcome by hard work alone. Communication between the states and the center gets affected by the fragmentation that exists within the system. One gets the feeling that Google remains the main source of information for the center on many ongoing development initiatives by states. My apologies for using many examples, but one last anecdote to illustrate this point. The voluntary national review of the SDGs that India submitted to the UN a few months back had a session on state level initiatives on SDGs. Just in time before the report was to be tabled, it was found that there are some errors which were timely corrected. Reason? Perhaps because direct information flows don't exist. The author who depended on web research to write the draft had one full passage on Punjab's SDG initiatives, just that it was about the Punjab province in Pakistan. Lastly, but it is not in the public domain. I mean, before the press found out, it was remedied. Lastly, are the mainstream policy discussions well informed by existing data? There is greater appetite in the media for database health stories now than before. We try to track our work at ORF, and our series where we teamed up with India Spend, a database-based web portal, during the last set of assembly elections was covered widely in the media. A story on UP's health situation, which analyzed district level data from annual health survey and NFHS, was carried by at least 50 different media portals and mainstream media outlets. Of course, there is sensationalism and alarmism when it comes to health coverage in media, but what I'm trying to say is that there are solid number-based stories as well. However, generally the quality of media discussions on health leaves much to be desired. Lack of analysis, wrong numbers, imaginary numbers, problems seem many. Other than loudly counting the child deaths when they die in sufficiently large numbers in any one hospital, the media doesn't talk much about health either, like we saw in the UP's case. Only last week there was a story in most major newspapers that Haryana records 39% of cancer deaths in India, cancer cases in India, and it will have 6.5 lakh of India's 17 lakh cancer cases by 2020. What the concerned journalist did was to use the Fortis Memorial Research Institute cancer registry numbers, which is a Gurgaon-based hospital, which basically said 39% of its patients came from Haryana itself, followed closely by Delhi and UP, two neighboring states. The adventurous journalist mixed this number with ICMR's national estimate for 2020, and he managed to scare every Haryanvi I know on Twitter. Such reporting often affects the quality of our discussions around health policy. To conclude, if the experience of the Clinical Establishment Act shows us something, it is that such initiatives will have to be led by the center. Like Dr. Paul mentioned in the morning session, many states may not have the technical expertise to do it. This is particularly true in the case of building a health information infrastructure where common standards, interoperability, etc. are key. Health being in the state list adds a major difficulty. If one looks at the fact that almost all the major initiatives in the country in the last few decades in health have been centrally led, health being in the list of state subjects is perhaps a binding constraint. This is particularly true as the stated objective of the government, as shared in the NHP 2017, is to eventually move towards a rights-based approach in health, which means legislation. Interestingly, at the drafting committee meeting of the Indian Constitution, both Dr. Ambedkar and Nehru supported shifting health from state to the concurrent list. Ambedkar was of the opinion that central legislation on concurrent subjects would not take away from the states the right to administer them. In fact, the Ministries of Health and Home Affairs jointly suggested the amendment, and Nehru supported it by saying disease is not something local. Despite explicit support by Ambedkar and Nehru, the amendment was dropped because UP, Assam, Bombay and Bihar opposed it. You will notice that none of these states other than Maharashtra are doing too well in health now. Perhaps it is time to reopen the debate and have a centrally led healthcare delivery system which takes into account regional differences based on a robust health information infrastructure. able to help address issues of access, quality, and equity of care. Perhaps this can be an area to learn from the USA and otherwise dangerous example for healthcare. With the passage of the Civil Rights Act of 1964 and Medicare legislation in 1965, there was a legislative mandate in the US for equal access to hospitals, leading to hospitals collecting data including on race and ethnicity of patients. An institutional mechanism to coordinate efforts at the national level, a forum on health and nutritional statistics perhaps, based loosely on the forum on child and family statistics of the US, can also be considered. A similar mechanism was recommended by the Niti Aayog recently in its 3-year action agenda. It is important as states with the poorest health indicators also have the greatest difficulty in spending the meager resources. The Niti initiative focusing on competitive and cooperative federalism talks of state-level monitoring of performance, which will lead to performance-based incentives from the center to the states. In this process, reliability of the data from health information systems is very important. Also, since the system relies on HMIS, HRIS, and the surveillance databases for key indicators, it is important that the states which manage to collect reliable data are not punished in terms of resource allocation as against states reporting attractive but unreliable data. I hope this 2-day conference discusses some of these issues and offers some way forward. Thank you so much.
Thank you so much. Thank you very much. You were right on time also. Thank you. I have pleasure in introducing you all to Mudit Kapoor. He looked so familiar, so I said, are you a doctor? And then he said, no, he was in AIIMS, but not a doctor. So anyway, I've met you before. It's a pleasure meeting you again. Now, Mudit Kapoor is an associate professor of economics at the Indian Statistical Institute. It's one of our finest institutes in the country and have long felt that it should be very organically linked up with the Ministry of Health to help us build the whole statistical discipline with us, but it never took off. He has formerly worked at the Indian School of Business in Hyderabad and the World Bank in Washington, D.C. His research papers have been published in international academic journals such as Management Science, Journal of Econometrics, Review of Economics and Statistics, Regional Science and Urban Economics, Journal of Financial Intermediation, Economic and Political Weekly, World Economy, and BE Journal of Economic Analysis and Policy. Have you all understood that? Currently, he is working on data and analytics in healthcare, where his mission is to convert data into information for optimal decision making. In this endeavor, he has partnered with large public and private health institutions to help improve performance in terms of resource utilization, identification of healthcare acquired infections, etc. He has also partnered with a research think tank to democratize health-related information by creating a health monitor index, a tool to assess government performance at the level of a district. He has a PhD in economics from University of Maryland in College Park, USA, and an MA in economics from the Delhi School of Economics. So all of you be careful. So here Mudit is, we'll take another 10-15 minutes.
Thank you, sure. Good afternoon. Thank you very much. I think, what we have heard in the morning, a very broad view of the healthcare, which makes the healthcare sector sort of, the problem looks at least very impressive, if we can solve it. So just the problem statement. But some of us who work with data, who work at a very micro level, sort of microscopically looking at the data, sort of look for the devil in the detail. So my presentation, or what I'm going to talk about, is the detailed aspect about sort of problems in the healthcare, but at a very micro level. What are the ground realities that exist? So there is a discussion that happens at the top, and what the ground realities are could be very different. And, I decided, just to be counterintuitive as a researcher, to start my research with the last slide that I would present, which is, what is the role of data and analytics? I think, most importantly, its role is essentially what Hayek summed up, to sort of demonstrate to people how little they really know about what they imagine they can design. So the point is essentially, the point of data and analytics largely is that very often we have very good intentions. But unfortunately, there are unintended consequences of good intentions as well. And data and analytics actually demonstrates that maybe good intentions is not sufficient when you want to deliver a healthcare policy at the micro level. And that's where I think the advantage of data and analytics is. So 2 years ago, I mean, just to give a personal touch to the presentation, 2 years ago, very blindly, I sent a proposal to All India Institute of Medical Science. And the whole purpose of the proposal was that, look, everybody in India talks about shortages of healthcare resources. I mean, you look at the numbers, we can see, you know, the World Bank data reports, we have 0.7 beds per 1,000 people. I mean, even this morning, it's all about increasing resources, increasing resources. But we as an economist sometimes think about, are we efficiently utilizing the existing resources or not? I mean, that's a fundamental question that we need to address, because if we are not, then maybe increasing further resources might not have the desired outcome. So with that intention, this was just like a one-line proposal sent to AIIMS, sir, that could we use your data and analytics to understand whether you are efficiently utilizing your proposal. And shockingly and surprisingly, 15 days down the road, I get, yes, why don't we have a look at the data? So if you were to go to All India Institute of Medical Science, it seems like a very crowded place, you will not get an appointment. But when we started looking at the data, we were shocked. You know, you look at the OPD appointment. Right now, if you wanted in the OPD appointment in the medicine department, it'll probably take you 3 months to get an appointment. But if you look at the capacity utilization from the data, it's only 70%. 30%. That means 70% of the days, it does not see the number of patients it has the capacity for. And the problem essentially is not that they don't want to see patients. There's no malice out here. But it's just that they were not using analytics to decide how many patients they should call. Because patients were booking appointments, but they don't show up. Now, problems like that can only be tackled not with good intention, but you actually need an analytical tool to solve that problem, that when a person comes in, what is he going to show up or not show up for the appointment? So then we applied sort of queuing theory from, you know, the airline industry or other industry into healthcare. Because one of the biggest challenges I've noticed in healthcare delivery essentially is lack of process innovation. There's so little competition in healthcare. If you look at a government hospital, what is the competition to it? Even the private sector is very heavily concentrated when you look at it in terms of concentration. So as a result, we have to rely on big innovations to deliver here. But who all have, if you look at growth of any economy at a very micro level, because growth is not macro. I mean, macroeconomists like to discuss growth, but growth happens in an organization, it happens in a firm, it's productivity about an individual. So when you look at it, research after research has shown that much of the innovation that the world has taken advantages of is actually process innovation. It's not product innovation, but process. Like, for example, when you build a car, the internal combustion engine was invented long ago, but it's only in the 1970s when Toyota told us that you can actually make a car more efficiently did it revolutionize to a certain extent the automobile industry in terms of delivery of the car. In healthcare, unfortunately, such process innovation has not happened for whatever reason. I believe it is due to lack of competition, and it's across the world. It's not that India is subjected to it. But by and large, such kind of process innovation typically happens in a competitive environment where it doesn't happen in a non-competitive environment. So I was actually shocked because I approached the private sector. Private sector said, no, we are all efficient. But then I said, if you're running an 1,800-bedded hospital, how is it that your occupancy rate is 65%? You look at the annual reports of private hospitals, AIIMS will report something like 81% occupancy rate in the private health. Now, you can actually do analytics to say, why is it, I mean, is India less healthy? I mean, Shamika presented inpatient, but where are the patients? I mean, why? I mean, we would imagine that there would be 100% occupancy rate. The moment you look at the data, it doesn't turn out. So AIIMS, I mean, it was shocking to some of us who work with data that we got access to their data. I mean, in fact, they wanted from us not sort of any analytics, but help them improve how data should first be collected at first place. What are the efficient ways in which we can collect data? And within 6 to 7 months, we started producing sort of data generator, and I'll demonstrate to you what we have done for them. In terms of at the micro level. So our focus is not at the very macro level. I can't give you what the macro answers are. But as India digitizes, as this digital data becomes available, even sometimes, ma'am, with unreliable data, we can identify patterns to educate the person collecting the data that, look, there's something amiss out here. There's something not right because data is showing. For example, I was looking at the HMIS data from the district hospital, and I showed suddenly to the CMO that in the last 8 months, you've not had a single infant mortality in this hospital. This is even an American hospital will not be able to show such. Now, then they begin to wake up that what's happening? Why are they not recording this data? Where is this data going? So data provides a lot of answers, but you have to do the analytics on it. It's one thing to just collect the data, but to be able to do the analytics to it. So I'm going to sort of demonstrate, how data and analytics can actually be used to improve quantity of care and also quality of care. And inform and guide policy. There are big pictures also that can be addressed through data. Some of the big questions can also be. So first demonstration is the quantity of care in terms of OPD appointment scheduler. The biggest problem when I went to the data team out there, Dr. Deepak Agarwal is not here because we collaborate a great deal together now. He says, Mudit, my fundamental problem essentially is of no show. So now imagine from policy perspective, we are wondering that patients should be there, but the patient is not there. He's booked an appointment, but he or she has somehow decided not to be there. And it varies from department to department. In orthopedic, unlikely that a patient will not show up, but in medicine, very likely that a patient will actually not show up for the appointment. So it varies from department to department. So they just gave us the 3 million data points that they had. And then we built for them an automated OPD scheduler. And what it does in a remarkable way essentially is that we then apply, what it does is, for each individual, the moment he books an appointment, based on the characteristics of the individual and the data we have, we are able to predict a pattern. How likely is this individual to show up for the appointment or not? Now, the beauty of this system essentially is that to each individual, I can assign a probability, and then we can decide for the 200 appointments, how many more appointments you need to give. So now, suddenly they realize that actually they need to overbook, but they need to do it optimally. We took into account the fact that if you call a lot more people, they might actually show up. That event is a possibility. But then it's a rare event. We can sort of minimize that possibility of the event. So now they were wasting, doctors' time, nurses' time in deciding how many people to call. Now imagine a useful resource like a doctor and a nurse, instead of working on medical problem, is actually working on non-medical analytical type of problem. So now this is automated, essentially frees up the nurse's time and the doctor's time to focus on the delivery part of the healthcare. So this was this is sort of demonstrate how analytics is used. So we had optimal resource allocation, large number of patients are being served, the waiting time was reduced very significantly, and better quality of care. Now you have a system where the variance in terms of patients showing up has reduced significantly. Now you sort of, doctors have said, I want to see 200 patients, let's say in the medicine department, the doctors. Now they're getting a steady flow of the patients that they need. But at the end of the day, this has to be implemented. So we are now piloting over there. Now the implementation part essentially involves with the technology team on how a solution like this is implemented. But the key thing essentially is to look for solutions in the data, get the right set of people, because you don't have to be a medical doctor to provide a solution. You need to be sort of an analytical person to be able to solve this. Then they said that we are suffering from another major problem, which is healthcare-acquired infection. It's also called nosocomial infection. And you'll be surprised to know that they have 37 inpatient departments where they have 37 nurses along with doctors trying to figure out whether a patient has HAI. Now, the unfortunate problem is many people think that this is not a problem, but if you look at, for example, Shamika says out-of-pocket expenditure in inpatient has gone up. One of the biggest adverse impact is due to this. It prolongs the length of stay. Superbugs is a major problem, and you'll be shocked to know that in the ICU, for example, it can be 13 times higher in developing countries than in developed countries. 10% of the patients who are coming right now in the hospital system, public and private, can be subjected to this adverse event, which means the length of stay going up from 5 days, it could go up to as much as 20 days. Now, so for the hospital system, this means that another patient will have to wait much longer period of time in already an overloaded system, takes a much longer period of time to get into the system. So then, sort of we needed to develop a solution which was automated and sort of which required very little human resources, because you have 37 nurses, 2 doctors engaged in doing this. Again, resources being diverted from healthcare to something which, is something manual and repetitive. And look at the way they were doing it so far. It's sort of very manual for each patient. Now, AIIMS has 250,000 inpatient admitted in a given year, more than that actually. Now, for each patient, they have to determine whether this could be a case of acquired infection or not, because that's the protocol they have to follow. Now, this we thought was very manual, it's repetitive, can be automated. So what we did, we basically created a fully automated system that essentially is just now a dashboard. Now, predictive analytics can be done to understand that is HAI restricted to a particular bed? Is it in a particular ward? Who's the cat? Now, all this analytics becomes possible because you need somebody. So, analytics, what it does, the power of analytics is not necessarily solving the biggest question that you have, but introducing innovations through answering these small little questions that you answer. And suddenly you realize that 1 year down the road, when you address these small questions, that you've actually had a huge impact. And I'll show you, like for example, in our length of stay study, which I don't demonstrate here because we are still finalizing it, we were able to demonstrate how length of stay is a function, irrespective of the risk factors. It's a function of the day on which the patient was admitted. So if you think of it as a lucky draw, that you got admitted on Tuesday with all the risk factors, it would take you 5 days in the hospital, but just in case you came on Wednesday, it would have taken you 8 days to remain in the hospital, spend 3 extra days. Now, the administration was not aware why this variance exists. So suddenly they realized that the way the surgical room was being prepared was not of the most efficient order. So you see, data sort of informs, the analytics on the data sort of informs the management what the best. It's not that they don't want to do it, but unfortunately, they don't see this kind of analytics to make informed decisions.
3 minutes.
Now, very quickly, what I would like to do is sort of, can we use micro-level data to address sort of big picture question? Yes, I think Umen has already referred to our study. This is a gender bias study which involves Shamika out here, Dr. Deepak, Ambuj, and Randeep Guleria. This was sort of a joint effort between AIIMS, ISI, and Brookings. And we do find, huge. So now policy questions are that this policy discrimination is not because AIIMS is sort of discriminating, but that's the way the households are behaving when it comes to healthcare resources. So how do we sort of change this discriminatory behavior which the households have? Now, everybody likes to talk about, we need to increase healthcare expenditure, but let me put up sort of a very macro view. You look at the blue line is the infant mortality rate of India. You look at what it was, almost 160 in 1960. So 16% of the kids that were being born actually died. I mean, this is massive. But the beauty of this graph is that there is a great convergence happening in health. I mean, with all the negativities. So then I plotted, was there a dramatic change when India started spending a great deal on healthcare? So, now I have data on healthcare per capita expenditure. There doesn't seem to be, like Dr. Paul was mentioning that when National Health Mission came, there was a slight bump in the IMR. We don't see it actually in the data. I mean, our statistics is not revealing. They might have seen what seemed like a big change was actually a by chance change. It was not like, but the good news is that something in the program is working. I don't know what precisely it is. And of course, people say Bangladesh, has overtaken India, but it overtook India way before 2000. Their rate of decline in IMR, and this could be related purely due to non-healthcare reasons. Maybe they have these self-help groups. Maybe they have a microfinance revolution that empowered the women. Education happened. As a result, the healthcare costs came down. But the point I'm trying to make essentially is that you can actually see from the data even big pictures, which very often you will sort of miss. Well, I'll not get into the economics. Maybe I'll take it in the question answer session. The economics of healthcare delivery is an important issue which data and analytics can answer. I mean, healthcare is a risky business at the end of the day. So analytics becomes important, and it suffers from, I'll explain what bowel cause disease is, but healthcare is subjected to some very large cause disease, which means that as the economy grows, the paradox is if your economy grows, the healthcare expenditure are bound to grow. The cause of it is actually growth. And the reason is because if other sectors in the economy grow, they are able to make all the common resources which healthcare is using more and more expensive. It could be rental of land, it could be capital value of land. management, for example, becomes extremely expensive. So this is what is called a Baumol cost disease, that if you want to keep the healthcare expenditure low, unfortunately, you'll have to kill growth. But that is something that you can't do. So that's why data and analytics sort of becomes extremely, extremely important. Thank you.
So now we have the last speaker on the panel, Dr. Paulo Henrique de Almeida Rodrigues. I hope I pronounced it okay. Is a Brazilian social scientist, professor at the Institute de Medicina Social, the Universidad, Rio. He's in Rio. Institute of Social Medicine of the State University of Rio, and of the Mestrado de Familia, I think you can say it, okay? Master Program in Family Health of the university, and director of the Center for Brazilian Health Studies Center. Now, Dr. Henrique has a Diploma of International Cooperation and Development by University of Ottawa, and a PhD in Public Health. During his academic career, has developed research and published several books and scientific articles about social policies and healthcare policies, some of them including the relationship between the Sistema Único, the South Brazilian public healthcare system, and the federalist arrangement between the three levels of the Brazilian public administration, federal, state, and the municipalities. For 20 years, Dr. Henrique worked at the Brazilian Institute of Municipal Administration, developing technical projects for federal, state, and municipal agencies in Brazil, as well as foreign governments. So, Dr.
Well, I want to thank very much for this opportunity to be in India and in this conference. I will excuse myself because my English is very different from your English. It's not I don't use it frequently, but I was requested also to make 3 talks here. And the most general one that will deal with our public health system is the last one. So some of the subjects I'm going to talk about now, probably you might not follow easily. Well, I belong to those institutions. SEBIS is social movement. It was the first institution in Brazil that started to fight for public health system. It was founded more than 40 years ago. I am one of the directors of it, and we work all over Brazil. Well, I'm going to talk about the Brazilian experience in health information, okay? An overview of it. Our public health system is SUS. In Portuguese, SUS is a single system of health, because we had different public health systems before 1988. So when SUS was created, we had to unify, to put together different state systems of health, different municipal system of health, and 2 different federal system of health. It's incredible. We had 2 federal systems of health before 1988. So one of the big problems of it is that the information should be the same in all the system. We have more than 100,000 health facilities in the country. So they should speak the same language. They should use the same indicators of health. And so we needed to have information system that worked all over the country in all health facilities. We don't have any health facility without electricity. All of them, 100% have electricity. So most of them have computers, but they have different kinds of computers. So it was created a special department of our Ministry of Health called DataSUS. DataSUS is to process it was built to develop all the systems that would be used. Initially, it worked in this National Foundation of Health. Then it came to the ministry. It was transferred to the ministry. I worked with them for a long time. And we have 27 states. You have, in fact, 26 and one federal district. It's almost the same number of states you have in India. You have 28, I think?
Yeah, we are 29.
29, okay.
Yeah.
And 5,565 municipalities. We have 3 levels of government, okay? So in a country that has 185 million square kilometers, the territory is larger than India, although the population is much smaller. We have 210 million people. There were different information cultures and computer technologies in all those health facilities. This was a big problem. So DataSUS was created to become an intelligence center of the healthcare system. It was created from another department that belonged to the Ministry of Social Security, because the Ministry of Social Security was responsible for one of the federal health care systems. And so they took 700 IT professionals from DataPrevi, the other department, and to create DataSUS. And the problem is they had a mainframe culture, another microsystem culture, and for the public system, we needed a microsystem culture because we needed to operate in any kind of computer. So they had to be trained before they start to develop the systems. And this took months of training of 700 people, and they developed different software initially based on DOS, because they had to be very simple, because some healthcare facilities had very simple and old-fashioned computers. So they had to install them in all those 100,000, around 100,000 facilities, and train thousands of state and municipal and even healthcare facility staff all over the country. So it took it was a very strong effort to do that. And also they had to organize a national procedure to gather and transmit data from each healthcare facility to the central level. And through the municipal level, then to the state level. They gather in the municipal level, then in the state level, then at the federal level. So it was, the issue was how to build up a culture of information in the whole country. And so it's a big issue. It developed diverse solutions, like there's a national register of healthcare facilities. Every private and public facility is registered there. Every month, the information is updated, and you have all the doctors, all the nurses, all the professionals, data about them, about the physical aspects of each facility, how many beds, how many diagnosis systems they have. Well, there is a new system for laboratories information system. There's it's being implemented now, the medical clinical record system. And the most important of them are the following. There's ambulatory information system, oh, it's not showing, and the hospital information system. All the money that flows in the system from the federal level is based on the information that comes from each health facility. So the money that will go next year, the budget for next year, is decided on the basis of the performance of the previous year. So this is very important. And I can show, I had some commenters, okay, some comments that they don't come up here. Okay, So those ambulatory information and hospital information system are probably the most important systems. There's also this regulation information system that's for schedules and is also for regulation. If the people who are being sent to specialists are correctly sent. So there are protocols and there are doctors who are regulating the system. Every appointment is checked before it happens. So this is kind of solutions. There are also disease management solutions like National Register of Hypertensive and Diabetics patients, National Immunization Program Information System. This is one of the major achievements of Brazil. We have an excellent national immunization program, and all is registered in this system. There's another system for maternal and childbirth information system that has improved a lot information about, because we missed lots of information. Now we have fairly precise, reliable information about maternal and childbirth cases. And primary healthcare information system, this went through a major change. 2 years ago, it was changed abruptly and not a very wise way, and we lost since then, since December 2015, all the information of our primary healthcare system, all of the information. They changed for a new system, but this new system is very complex, requires broadband to transfer data, and most healthcare facilities don't have access to broadband, and they don't have computers that can deal with the system. So only in 11% of our primary healthcare nowadays can fill the information. So we lost the information we had for a long period of time. The other system was running for 20 years, and it was pretty good. And they decided to change it without knowing the country. The persons who decided to do that didn't know the country. Well, this is a major problem. We have different epidemiology and surveillance systems, like mortality information system, national notifiable disease information system, national childbirth information, and other systems like that. And they installed all over the country, and the information is getting more and more reliable. It's not the case with our primary care information. And all the information is public, is open for the public. Has been democratized since the beginning. It was developed with this purpose. So it's possible for any citizen, everywhere, even here in India, to check what is happening in every healthcare facility in Brazil. So I don't know why, but some of I have some things that they don't show up here. I don't know why. So this information can be, they developed special software to retrieve and to offer this information to the public. Tabnet and Tabwin were developed by DataSource for that. They're free, anyone can use it, very easy, and they are compatible with Excel, with GIS systems, and things like that. So every public health facility is geo-referenced, so it's possible to know where things are happening. So all this information is open, as I said. This is the link for that, datasource.gov.br. You can take this. So anyone can make tables, charts, or maps using DataSource tools. Okay, so and they are compatible with different systems, as I said before. So here's the page. Like we can go through epidemiological, healthcare, network, facility, vital statistics, demographic, because it's linked with the Brazilian Institute of Statistics and Population, like the Indian you mentioned. So that you have demographic information, up-to-date demographic information associated with health information. It's possible to associate this information. And also we have information of our private healthcare system. There is a special agency, a national agency that controls the private healthcare system, and the information is compatible with the public health care system. So there's an example of indicators that we can get from that. Just examples, we can create our own tables and charts and graphs. There are different, all the epidemiological and surveillance data are possible to be retrieved. Demographic and socioeconomic data can be found, and we can find information from the map, so we can go to any state and ask information for every municipality or of every healthcare region in Brazil. It's possible to create tables in different ways. After choosing the option, the user can generate those tables and charts, tables like that. We can use them in Excel and so on. Well, but we have recent bad news. After all this effort, since the 1990, almost 30 years, they stopped to hire IT professionals for data source. So most of them are retiring, and they are hiring nowadays private companies to replace that's the intention. It didn't happen completely, only in the private healthcare to replace the previous private healthcare system. But we have an idea about what can happen now. So we don't, most of them are retiring, and the Brazilian government is prioritizing this hiring a private company. So when we outsource our intelligence, that may be a big problem for the future, because we can lose control of it. And we have a fairly good control of information in Brazil. So this is a big danger. We can have the problem that happened in the private, in the primary healthcare system can spread for other information systems. This is a very important threat nowadays. So we are dealing with this now. There are people struggling against this in Brazil. SABIS is struggling against this, but our political situation is very difficult nowadays. We have a very conservative government that resulted from almost a coup d'etat last year, and 95% of the population is against it. It's a very corrupt government. There are lots of criminal justice processes against the government, but they are managing to survive until now. And they are doing this kind of thing. So we are in a very difficult situation in this moment, and they're also decreasing money for health. I'll speak about this later on. I think it's in time? Okay.
Thank you very much. I would like to thank all the three panelists for really adhering to the time. Now we are open for question answers. If anyone would like to ask a question from any of the panelists, please do so. You can introduce yourself and ask a question. Let me give the lady. Mudit, really brought out the whole importance of use of technology and digitization of information and data analytics. It's so important that he has done it in AIMS, but it can really be used across the system. As a principle, it is something that we need to do. Really, we are sitting on mountains and mountains and mountains of data, if only we could analyze. For example, just in AIMS or Safdarjung or even private hospitals, to see if you take the diabetes data together and just digitize and analyze just that data, patient data, you can really understand what is happening, whether our treatment is really effective, is diabetes of the patient coming down, how long it takes, and so on and so forth, several other insights, which could then go into a better and a policy from the government. So I think there is, but of course there are 2-3 very controversial statements he's made. Unfortunately, we don't have the time to contest him, so we'll let him go. You're lucky. So otherwise I would have hold you to account. The one was IMR hasn't really shown up after post-NRHM. Well, Chris Murray himself, the guru of data, says that India has doubled its pace of reduction, both maternal and infant mortality, post-NRHM. So NRHM did have an impact, and counterintuitive it would be if we said there was no impact at all, because before NRHM we didn't do anything at all, and post-NRHM money was pumped in, interventions were pumped in. So they must have, you cannot have a situation where somebody is really doing something and say there's no impact. Could have been more or less or something, but I think I would like you to look at your data once again. I don't necessarily agree with that. Finally, Dr. Rodriguez gave a very interesting presentation on Brazil. I think what I take away from his presentation is the enormous amount of attention they have paid to data cohort. Building the cohort is so important, and that's why he's so upset that it's being interfered with. So now the comparability will really be affected. What we in India lack is this cohort information, on a long-term basis. So we are not able to really analyze. It's just 1-year data, 2-year data, 3 years, and then there's gaps, and then something, the indicators change, and so it's becoming very difficult to really compare, and we're constantly doing comparison of apples and oranges. So, and then the use of IT and the capacity, the amount of time they spent on identifying people, teams, and training them, and standardizing the whole information system in the country. We have not done that. We have these centrally driven data formats, HMIS, but one has to really look into the details to know the various interpretations that are given and information sent up. So there's a lot, I think, that Brazil has really taught us. And it's so interesting that the large amount of data sets which they have put up separately so that it becomes so much easier to correlate and get to some policy solutions. And I would tell you one thing about Brazil is because of their data structures, they've been able to, they're one of the few countries in the world that has good quality data to show the efficacy of primary care. You heard Dr. Vinod Paul say how primary care must be given its due place, and that is the most important. Their data will show how, due to their family health teams and their focus on primary care, they were over the years able to reduce by 50% hospital admissions, by more than 50% cardiovascular and hypertension incidents, and so on. And that's a huge saving. Mudit, the growth doesn't, increase by just because of GDP. It is that when your incomes grow, your quality of life improves, you're better nutrition, you don't die due to a low-cost childhood disease, you die because of a high-cost cardiac disease. That's it. So, if you want to be keeping your costs low, then let the kids die quickly. And don't let them grow beyond 65 years of age so that you don't get to those old age diseases which are expensive to treat. So that's the story. So the point here is, coming back to Brazil's data, it's a very, very important critical data set that they've been able to demonstrate the importance and efficacy of primary care. And that's exactly what we need to do in India to convince the advocacy Shakti to the politicians will only come when we are able to show that your primary care is effective and it saves lives and money. Thank you so much for your attention. We'll meet after lunch.
Thank you, Madam Chair, and all the speakers and all of you. We'll go down for lunch, collect again at 2 o'clock. We have two interesting sessions after that, and then a lecture by Professor Govinda Rao. So we have lots of work to do today. Let's feed ourselves.
Sunday afternoon, post-lunch, and India-New Zealand match going on. So those who are present here must be seriously interested, but it's also partly because of we have a star speaker, a list of star speakers here, and I'm very welcome. I'm very glad to welcome them. Professor Govind Rao will speak first, then Sujata, and then Shamika. That will be the sequence we'll be following. So we'll, topic as we all know, political economy of privatization, preventive versus curative care. I think three words that they have used in the title mainly define the scope of this particular session: privatization, prevention, and curative care, and the pulls and the dilemmas between these. So Professor Govind Rao will be speaking first. I have a trepidation really that Professor Govind Rao should be introduced to this audience. It's not necessary, but still as a formality. He's such an eminent person, currently an emeritus professor, National Institute of Public Finance and Policy. He was earlier member of the 14th Finance Commission, Government of India, and then also member of the Economic Advisory Council to the Prime Minister from 2004 to 12. He was director of National Institute of Public Finance and Policy from 2003 to 2012, a very long period. He's an expert in public finance and has written extensively on this issue, very eminent name in this field. Currently he's settled in Bangalore. So, Professor Govind Rao.
Thank you. At the outset, let me thank the organizers, Mr. Shakti Sinha in particular, for inviting me from to come all the way from Bangalore, particularly because I'm not an expert on health. My indulgence in health is very random, once in a while, as an error. Basically, I'm a public finance guy, and if you have done a lot of sins in your past life, you would be working on issues relating to public finance, because this is a very niggardly area, because we will have to say that no, money is not here, money is not there, we can't give more money, and basically, we are the doctor knows in the system. So I approach the problem from the entire thing from the public finance perspective, but also keep in mind, in fact, I had to rub shoulders with both Sujata and Dr. Bang that was in the high-level expert committee on universal health care. Sujata, in fact, I have read her several chapters of her book, and the passionate book, which is titled as "Do We Care?" The obvious answer is no. So I will approach this particular issue of privatization from the perspective of a public finance specialist. Healthcare often is misconceived as a public good. Now, in a strict technical term, healthcare is not a public good. If it is a public good, private fellows do not enter. There is no scope for private people to enter if it is a pure public good. Pure public good is defined as a good which is non-rival in consumption. That means if you consume more, others will consume less. I mean, in fact, this is non-rival in consumption and non-excludable. And neither of these things applies. Obviously, market failure that you are talking about for government intervention is not because it's a pure public good, but it is a good which is so meritorious, and it is a good which involves quite a bit of redistribution. It's a good which, in the past they called it a categorical equity good. It's a good which has significant externalities. And since it has so much of externalities, that it is imperative that the government should come in and do the things. In fact, this is a basic distinction that we need to do. The fact that it is not a public good, pure public good, does not make any the government any less requirement for a government intervention. So government intervention is absolutely necessary. But I just wanted to clear that misconception. Why private? So because this is there is rivalry in consumption, there is excludability. Private sector can enter. Otherwise, private sector cannot. In defense, provision of defense for a country, there is no private sector. It can get into the contracts, but then provision has to be by the government itself. So, in this particular case, when the government fails to provide public service in adequate quantity, then obviously the private sector sneaks in. And this is an area where huge profits have to be made, because there is something called asymmetric information. People don't really know, a patient really doesn't know what his problem is. And the doctor can dictate his terms. And obviously in that particular environment, if you do not have a public institution coming into picture, the private fellow can exploit, because health is like, it's a life and death of the people. And when you are talking about that, he is willing to pay anything for, to live. And in the process, what you do is, unless and until you have a very strong regulatory system in place, there is a huge amount of profits to be made, and the private sector gets in. And it becomes a business. India, of course, the constitution does recognize that government has an important role to play. Under Article 47, Directive Principles of State Policy says that it is the duty of the state to raise the level of nutrition and standard of living and improve public health. And then later, there was the Supreme Court has declared that it is a fundamental right under the protection of life and personal liberty in the Paschim Banga Khet Mazdoor Samiti and others versus the state of Bengal versus others case in 1995. So this is considered to be a fundamental right. And so the government has a duty to provide adequate public, health care to the population. So inability to undertake adequate public spending has resulted in the proliferation. We have talked about public spending. Now, if you include basic medical and public health, family welfare, water supply and sanitation, nutrition, RSBY, everything together, the total expenditure works somewhere about, has been virtually stagnant at around 1.3 to 1.4% of GDP. If you put everything together, if you take just the medical and public health, it is just about 1.1%. Basically that, and it used to be much less, but then it has come to that. Now when the requirement is so much, and obviously when the people are paying, spending out of pocket 5 times, so there is a huge business to be had for the private sector. So there is a huge vacuum that has been created because of the lack of governmental intervention, and there is a huge profit to be made, and then you have a regulatory system which is totally ineffective. Now, profit to be made in every possible way, whether it is in medical education, whether it is in provision of medical care, spreading of lots of businesses, etc. And you have a Medical Council of India, which is supposed to be a regulator, and if you really see this thing, almost more than 200 members of parliament have medical colleges. Now, in fact, this is one of the major issues that we have. You have more than 200 members of parliament running medical colleges. There is a nexus between these politicians and the Medical Council of India, and everybody gains except the people. So the inadequate public spending has been the major reason why the private sector to enter and proliferate. As I mentioned, supply constraint and asymmetric information makes healthcare potentially a profitable business. And not surprisingly, private sector has entered the fray in a very, very big manner. Shortage of doctors and health personnel has made opening of medical colleges and hospitals a big business opportunity. Given the license permit Raj of providing licenses and poor and opaque system of regulation of licensing, politically influential groups have been able to get into this business. Influential politicians from all political parties have been running the medical colleges and hospitals. It's not one party. Everybody is involved in this. These groups in turn protect the regulator. There is a major report of the Niti Aayog that has been, this thing basically disbanding the Medical Council of India, and nothing has happened. The report was produced almost 2 years ago. Nothing has happened. There is no reform. Now, there must be some reason why nothing has happened. They say that something is going to happen, but I don't know when. So nexus between the medical business and the regulators makes it impossible to undertake the much needed reforms. Despite the Niti Aayog recommending important reforms in the regulatory system, not much has been done. There is another nexus, and that nexus is between private businesses and the insurance companies. There is a public intervention is called for when there is a huge asymmetric information. And medical insurance business has a huge asymmetric information. When you subscribe to a medical insurance, you think that your marginal cost of going to a doctor is zero, because you have paid for it and in any number of times. So you keep going to the doctor for every small little thing. And doctor welcomes you because more the number of times you go, more the money he makes. And insurance company is not unhappy because the more the number of times, more this thing, the premium will increase later. There is a spiraling thing that goes on. There is a nexus between the medical business because they get the thing and the insurance companies. So there is so much of advocacy that has been going on for the private the medical insurance. Even if you are saying that I am doing the medical insurance at the governmental level to the poorest of the poor, basically it's the taxpayers' money. Ultimately, unless and until you have a proper regulatory system in place, insurance will go on spiraling. And you'll have to ultimately find out whether you need an American system in place or a Canadian system in place. Basically these are two widely different systems. And in Canada, you have a public involvement, it's almost 75% of the medical care is done by the public, by the government. So you have these nexuses, first between the politicians and the medical businessmen, and the second between the medical businessmen and the insurance companies. Now, and of course the low and stagnant budgetary allocation. In fact, while intervening, Sujata Rao mentioned that if you have a strong primary health care, a requirement for going to the tertiary or curative health care is less. That's why preventative health care is extremely important. And there has to be a much greater focus and much greater allocation to the preventative health care. If you really, you may put the norms. You say that 5,000 people you need to have a public health sub-center. But by having a small, a room there is not going to be a health center. You need to have the people there. You need to have the, the equipments there. You need to have the people there. You need to attend to the people. Then, you may say that there is a health worker who doesn't come comes only once a week. It doesn't really help the matters. And even, so we put the norms, but then you don't implement them. And there is no way that there is no mechanism to implement, force people, the state government to implement them. At the end of the day, look at the state governments or anybody, the governmental system as matter. You see, health is not a paying thing for a politician because there are no big contracts to be had. Unlike in many other things. So, people forget about it. Once in 5 years they come and vote. And there is not much of a consciousness that has been developed that the government health system has to improve. So low and stagnant budgetary allocation to the healthcare sector is not a random phenomenon. The lower the money for private healthcare, and the lower the money for the preventative healthcare, better it is for the private health businesses. There is a direct relationship between low allocation to the preventative healthcare and better business for the medical things. I mean, I am putting it in an extreme form because I think we have been talking about this for several decades now, but nothing seems to have improved. In fact, in the universal health coverage, and we did work out the amount of money that is required to improve the basic primary health this thing. In fact, the financing part was worked out by me, and we said that you need something like 2.5% of GDP. If you really want to, do the basic, go according to the basic norms. Dr. Bang had a number of other things, this thing. Of course, if that is the case, if you had, you would need much more money. But, sort of, even if it has to be 2.5% of GDP, there would be a substantial improvement. Of course, other reforms are necessary, but then allocation itself is a necessary condition, not a sufficient condition, but that necessary condition must be met. It is not easy to constrain the private sector and exploitation by the private sector. Asymmetric information is so much that, you see, when you bring a patient to the hospital, by the time he reaches doctor, he might die, but the doctor will not tell you. He will come back and then tell you that some surgery has to be performed on him immediately. You pay 2 lakhs of rupees. There are instances where it was found that on a dead body they wanted to collect money. That is the level of asymmetric information that we go on, and there is no way there is no regulation. Nothing happens to these people. Nothing. When nothing happens to them, when the probability of their being punished for this thing is virtually zero, things can go on forever. The way to limit its influence is to substantially increase public spending on preventative health care to ensure that people have access to basic health care services. Creation of sub-centers and health centers according to the agreed norms itself would require government to increase spending by at least 1 percentage point from the present level. And an additional spending of 0.5% for creating essential secondary and tertiary services would be needed. The most important issue that needs to be addressed is the regulation. In this country, we don't have virtually a proper regulatory system to deal with either the medical services or the medical institution. Thank you.
Exactly 14 minutes. Our next eminent speaker or panelist is Sujata Rao. Sujata has had a long career as a civil servant, 36 years of civil servant, out of which 20 years she spent in health sector. Sujata, that might be a record in Indian civil service. Yes, it must be.
Guinness record of
But parallelly, she also ran a parallel academic career. She has been Takemi Scholar at the Harvard School of Public Health, very serious student of health economics. She doesn't mention in her biodata, but I remember that I was a member of a commission of which she was the secretary, National Commission on Macroeconomics and Health. So economics, financing of health sector has been her core area of her studies, work, and as we know, she has recently written a huge book, Do We Care? India's Health System. Now, I have read that book. What comes out is her passion, her pain, I would even say, pain, frustration about the way India's public healthcare system has been run. It can be improved, but it is not improved. So all those suffering that she has seen, witnessed, and probably also participated in shaping the public healthcare system in India, that all her experience and wisdom is instilled in that book. So, Sujata, please.
Very humbling introduction, I must say. Kind of makes me wonder who you're talking about. Anyway, it's a very interesting topic that has been given for this afternoon, and I was quite amazed that we're talking in terms of political economy, because in health discourse in India, public health discourse in India, we only keep on beating our breasts on 1% to 2.5%, 1% to 2.5%. That's all that we talk about. Not necessarily look at saying that why are there low resource allocations, understand the dynamics that really go and influence the thinking and the context in which health and health discourses are being looked at in the country. And so, you know, our debates are very, very simplistic in a way, and we are not really looking at the big picture. So what do I mean by that? I say that the thinking on health is but a part of the entire overall intellectual thought that goes into making political systems function. Really is also in India influenced by what happens globally. It's not as if India is isolated. Whatever happens globally, that thought also influences our thinking and our direction in the country. So when India won its independence, the dominant thinking for the post-colonial countries were welfare state. That we are a welfare state. We took from the UK the Fabian thinking that the state has a role to protect its citizens from, against poverty, ill health, and sickness, and so on. While UK took up National Health Service as a consequence of post-World War. Of course, we could not aim that ambitiously, largely because India got its independence at a huge human cost, as you all know. Massive famine, world's largest migration of people, and we were trying to get 600 principalities. I mean, we couldn't even divide a state of Andhra Pradesh properly. So you can imagine getting 600 principalities together to become it is a huge challenge, and I can forgive those 10 years of the politicians for having given a slightly lesser attention to health. Even so, even then, we had 75 million people affected with malaria, and in 76, that's 22, 25 years later, despite all these problems, you remember that was a time when we were dependent on getting basic food that used to be imported. So from those days, by 75, we could eliminate and eradicate smallpox, bring down malaria from 75 million cases to 2 million cases, and get a grip on and start the process of paying attention to primary care. But this is when, in the 70s, globally again, in US, some economists, and I forget the name of the particular economist, but came up with saying, why can't health be a tradable commodity? Why can't health be a commodity where markets can also play a good role in trying to arbitrate the allocation efficiencies? So with that came in Reaganomics and Thatcherism, and so both Reagan and Thatcher became the principal proponents of this new way of thinking that health should be open to the markets and not be protected by the state. And that again influenced our thinking too. And in '84, the biggest entry of Apollo came up as a corporate hospital, was introduced in '84. Now, this kind of liberalized thinking and the pushback that it gave to the role of state as a premier and a primary unit of intervening in health really then started from '80s. But it was not only that thinking. The subjective and objective conditions within the country also propelled such thinking, because the economy really started sliding from mid-'80s, as you all know, and early '90s you've heard about gold being mortgaged, and we had to have IMF conditionalities, and where the health budgets were completely chasing the fiscal deficit problems, our budgets were completely nixed to the bone. And the only programs that we could implement were those that were funded by the World Bank, that is the vertical disease control programs. Now, this was again a pushback. I mean, the disparities between the rich and the poor did start in, say, 60s and 70s, that gave rise to the Alma Ata Conference in 1976, where all the developing countries, then, there was this cry for saying that health is being neglected, and therefore the Alma Ata Declaration of WHO Conference in 1976 made us all sign we were signatories to the resolution to say that we will implement comprehensive primary health care as a first fundamental human right of all our citizens, and the states will do that. And that comprehensive primary health care meant not only the right to have access to basic healthcare services, but it extended to the social determinants of safe water, nutrition, and sanitation, and so on. So it was a much broader definition of what primary care must mean. Now that meant a lot of money had to be put in, which we didn't have. It coincided with our national health policy in '82 did reiterate many of these, but then the economy was not adequate. We were not able to afford it, and so therefore, as a part of the structure adjustment, World Bank came up saying that you cannot afford, you're too poor for that grand vision, so you take selective primary care, and then primary care became equivalent and synonymous with TB and malaria and leprosy and reproductive and child health and so on. So this was how the entire story started, and then there was this growth which was giving higher aspirations to our middle classes who were in need of non-communicable disease programs. They needed to be treated, and that's how the private sector started. They made a modest entry with Apollo's in '84, the corporate sector, and from then on, by 2000, now you see what Shamika showed us today, that the majority of IP and OP is being managed by the private sector. Now, the private sector not only got into public service, health service delivery, they are in manufacturing of drugs, they are into medical devices. We don't manufacture, but we import, and it's a private supply. We don't have our public sector involved in it. And then we have medical education. Doors were also opened up in the late 90s when you really see it. Otherwise, previously it was basically government-funded medical colleges, which very little fees. I mean, a medical student those days would pay 10,000 rupees annual fee. Okay, and now, yes? Even lesser.
I paid 800.
800 rupees. So that has, just imagine, nurseries, kids going to nurseries paid much more. So that was a public good, sir, because that was the way the politicians thought that creating doctors with no financial outgo would create doctors who are more interested in patient care, not in how do I make up my money. But the commercialization started when we began to open up our doors for private sector to enter in. They brought in huge investments. They had to earn money. It was a business investment, and they were into saying, how do we get money? So when you're paying 3 crores of rupees for an admission, it's very difficult to tell that person to say, now go to a primary care center in Bhagalpur and work over there. It's not possible. The two sets of facts don't. So that is the political economy of our healthcare. And that is a political economy of, and when he says that 200 medical colleges are run by politicians, and I can tell you the non-reform of MCI. MCI in 1998, the infamous leadership of MCI got in, no names. Twice before 2010, the Supreme Court set it aside, twice. 2010, there was a CBI inquiry, and we issued an ordinance, our secretary then, setting aside the whole elected council, and we had 6 most people of known integrity appointed as board of governors. That ran MCI for 3 years. And then later on again, they're back. Now the reason for why MCI doesn't get reformed, even though everyone is aware of the huge amount of damage they're doing to the human resources, both in terms of quantity and in terms of quality, is largely because there's not a single political party who doesn't have his hands into the till. It is not a question of one party or another party. No. So secretaries are chota mal. You're giving us too much of importance. So the issue is, so why doesn't that happen? Now, so you can, what is political economy? Political economy is a word that really came out of leftist literature, which really does an analysis of all the stakeholders who influence, who have a stake in a policy system. I mean, I wish I had brought the Oxford Dictionary of what political economy means. So when you really look at health picture and become a class stakeholder analysis, what are their motivations, what are their requirements, what are their needs, then you will be able to get to know the huge amounts, arena of conflicts of interest that lie at every stage. Government reduced the stent prices. There was price gouging going on stents. We all know that now. And government rationalized the price. But has the consumer benefited from it? No. Why? Because the private sector was able to shift the price that they saved on the stent to the surgeon's fees. So this is the way in which this kind of, I'm studying that. नहीं वो हॉस्पिटल बिलिंग में सर्जन को दिखाएंगे ना, ये थोड़ा दिखाएंगे कि मैं घर ले गई
मैनेजमेंट
हाँ मैनेजमेंट तो ठीक है but the point is they'll show in the billing surgeon okay you're below poverty line चलो हमारे साथ so this kind of thing is where and now the next point is that really regulation is the only way we need to have a strong provider regulation, but that is again weak, and I feel that this is the way in which the political system is subsidizing. Besides giving land and giving custom duty exemptions, giving income tax breaks, another way we subsidize the private sector is not to have a regulation and to have a laissez-faire environment in which they can operate in any which way that they want. So these are the compulsions of, call it electoral democracy, lack of vision or whatever, but privatization is really getting deepened by now, and that's not really going to help, because governance when you want to have private sector, you also need to have a very strong system of governance, a set of rules, regulations, procedures, protocols that you then hold the private sector and provider accountable to, and they need to be enforced also. Now whether it's in drugs or whether it is in devices, whatever it may be, you need an enforcement machinery which costs money. There's nothing called a free lunch in health. That's the first fundamental rule. So you can't have 4 drug inspectors in a district of 3 million people with something like a few thousands of pharmacy shops and expect this guy to really be seeing the quality of drugs that you're selling and so on. So these enforcement, these are typically the regulatory arm is where the government policy is really failing. And lastly, I would like to say that the current nature of private sector is something that we need to understand. When we talk about private sector, each one of us sitting in the room think of Apollo and Fortis. They are just 3% of the total private sector, though the 3% does take care of 3/4 of our needs for tertiary care, particularly cardiac and oncology and so on. But the rest of the 97% start from the quack upwards to small nursing homes and so on and so forth, who are not regulated. And they give any kind of care, what kind of protocols, look at the drug resistance that's growing, and so on. So managing them, and the Clinical Establishment Act was brought out in 2010, but not one state is implementing it. The institute, the Indian Medical Association is one huge trade union which is simply not allowing the Clinical Establishment Act to be implemented. And that is the kind of act which would have given us information like Brazil has, where public and private tell us what facilities there are, where are they located, what kind of doctors and human personnel have been appointed, how many beds for gynae, how many beds for pediatrics. That's all there was in the Clinical Establishment Act. It didn't say what price you're charging, nothing, just your infrastructure and in a form of a licensing that you're given permission to set up. Even that we are not able to get that information from the private sector. So the biggest in terms of data, when you say what recommendations do you have, one really doesn't, and when we are thinking in terms of, because today India is not in a position, too much has happened, India is not in a position except to get into a PPP mode. If you want universal access, government by itself through its own government centers, it is out of question now, whatever, maybe it's wrong, but that's it. So to partner with private sector, we need to know the nature of the animal we're dealing with. He's a big elephant in my room. I need to know what he's like. How does he get his money? How does he do his pricing? How can I safeguard patients' interest, safeguard government interest from being exploited? I must need to know what the private sector is all about and the financing. Now that's a big black box and we really don't know. So no PPP ever takes off because there's a huge trust deficit between the government and the private sector, because the private sector thinks government doesn't allow them to work, and government thinks if I give any rupee, then I don't get my accounts back, and they cheat on whatever conditions that we have laid down, then we are held accountable and so on. So there is a huge amount of operational research that needs to be mounted in understanding the private sector, and then only come to a negotiation between the two as to what services you can give where and how. And a large number of laws and regulations need to also be accompanied with this policy reform to see that private sector plays a more positive role for enhancing welfare and the well-being of the patients in our country. But till we do that, and for that you do need to have a very strong political system that is committed to the welfare of the citizens' health. And finally, I would say preventive care, though Dr. Govindrao has said health is not a public good, I understand from where he's coming, pure classical economic terms, but if you really look at it, whether it's immunization, infectious diseases, or whether it's air, clean air, all these all come under a public goods category. And if you're going to have 10 million people die of polluted air in Delhi, then there is something that needs to be done. In India, 10 million people.
You see, technically there is a definition of a public good.
I know. So I'm saying I agree with you,
No,
but we still...
It does not mean that you see it is any less important. That's the point that I'm making.
No, I'm just saying that these are public goods, these set of basic services and basic entitlements, and this is where the state needs to intervene and have a duty to perform.
On that there is no question.
Okay, later on debate between two of them. But thank you very much, Sujata, and again for completing exactly in 15 minutes. I have some questions too, but I'll put it later on. And our third speaker is Shamika Ravi. I suppose that she must have been introduced in the first session itself, and so I won't really spend time on introducing her again. Shamika, please.
Thank you, Dr. Pang. First, I'm going to give you a sense of what the data says as far as the private versus public status of Indian healthcare looks like. And then I'm going to make some theoretical arguments for the kind of PPP that we're all talking about. So we've already spoken about this. Now this is one slide I wanted to give you a sense of. If you look at public care IPD, who is going to a public hospital today? And how has this trend changed in, let's say, the last 10, 15 years? You will see that urban men are very less likely to go. It's essentially rural female increasingly who are going to government hospitals. So if you are seeing the overall trend in the economy that the utilization of government hospitals have gone up and private hospitals have come down, despite the fact that private hospitalization remains predominant in terms of IPD, the trend is actually that private is coming down and public is going up because of mostly maternal health programs that we are running. So increasingly institutionalized deliveries are happening in government hospital. But what also stood out interesting to me was that in urban areas, men are actually not going to government hospitals, okay? And very increasingly less so. Now, this is just to again break down the public versus private. If you look at the bottom row, all other ailments, over time you are seeing that overall hospitalization has increased and private hospitalization has seen an enormous increase, except for childbirth. This is just breaking down the data. Cesarean, normal, any other, massive increase in public hospitals, okay? And the reason is essentially the Janani Suraksha Yojana and the other schemes related. Now what we are seeing is with increased institutional deliveries, we are also seeing a decline in commensurate birth at home, home delivery. Now this was the objective of the program. So in that sense, we are attaining the objective of the program. Of course, a deeper question that can be asked is, Are institutional deliveries by themselves, should that be the objective? After all, hospital-acquired infection, as Mudit informed us in the morning, these are serious concerns. Also, increased burden of C-sections. And there is a private versus public breakdown there. We are seeing that in private hospitals, on an average, the C-section deliveries are close to 41%. And this is based on the last NFHS data. Public hospital, 12%. So if systematically you are seeing these differences, then these are very telling, and we should be careful what they denote. Now, we have already looked at these. Now, in terms of out of pocket, we have known that urban areas overall, the health burden has increased for all quintiles of people. In the rural areas, it is essentially the very poor. The reason this is important to reiterate is because remember RSBY, Arogya Shri, a lot of the health insurance schemes which are government funded are essentially targeted to exactly this segment whose health burden in terms of expenditure out of pocket is actually rising. So there is a problem there. Okay. Now this is to give you a sense of per IPD case what is happening. Overall people are spending a great deal on hospitalization, like we mentioned in the beginning, 66% increase in cost of hospitalization now. What are the different tenets? Average doctor fee, medicine, diagnostics, everything is increasing in very, very large amounts. What about insurance coverage? And this is something I did not cover in the morning deliberately because I wanted to give you a sense of public insurance versus private insurance. If you look at public insurance, private insurance first, across quintile groups, rural, urban, there is a break. Okay? Essentially, private insurance is urban and to the richer, higher quintiles. Okay? Whereas if you look at public insurance, the government funded ones, then the rural-urban gap is not that wide, and there is actually not that much of a wide gap across quintile groups. So in terms of just outreach, the government insurance programs, whether they are happening through the RSBYs or the CGHS or the ESIS or whatever, they are reaching a very large fraction across the different income groups. What is happening, we are increasing in terms of, and we've alluded to this several times during the day, that in terms of innovation that is happening in the health space, health policy, one of the largest outlays or promises we are making is in terms of expanding insurance coverage. In fact, that is going up from 30,000 to 1 lakh per household. What we are seeing over time, the data is telling us that if you have insurance coverage, you are very highly likely to use hospital facilities. Meaning, now, you can't really, I'm not trying to tell you that insurance is incentivizing necessarily pushing people into the hospitals. It could also be that earlier you did not go for that care and now you can afford it because you are insured. It's not easy to tell one from the other. However, the C-section difference is very telling. Okay? That systematically we have overutilization of facilities, overdiagnosis, all of those things happening in the private care, which is a cause of concern. Now this is broadly the theoretical take, and I want to spend 2 minutes on this. In India, just the nature of the healthcare markets, we are not going to have an overhaul of either country X or country Y type. We are a uniquely Indian model and we will remain so. The important thing to consider is how do we innovate from here such that both sectors can really deliver. And in that sense, the Indian healthcare market between private and public should really be conceived as, these are segmented market. Both parts have essential roles to play. If you consider market failures, then, the margins are very thin when it comes to preventive and primary care. So the role for the government is obvious. Okay? Private sector is not going to jump into primary and preventive care. But when it comes to super specialty, when it comes to tertiary care hospitals, India has some of the best tertiary care hospitals. In fact, medical tourism has been on a rise over the last 20 years or so and facilitated through government policies and so on as they should. But they both have separate roles. Now, primary care comprehensively will rest within the purview of the government, and that is something that Dr. Paul in the morning talked about in terms of the wellness center, just the kind of vision we have towards transforming a lot of the PHCs towards a wellness center, all inclusive, including IUs, different kinds of medication, training the A&M. So there is a lot of experimentation one should expect over the next couple of years. However, when it comes to, again, super specialty and medical research and training, medical research in India is almost exclusively coming out of public care. And we should not undermine that. I think it is very important to recognize that research and knowledge in the health space is almost exclusively coming out of public care or forms of PPP, so with a great deal of government support. What is the existing evidence? PPP is not a new term. In the infrastructure sector, we have sort of burnt our fingers a little bit because there was overheating, and that is one of the reasons for the large NPAs and so on. But PPP in the healthcare space is something that we have been experimenting with in the form of, a lot of our tertiary care private hospitals receive free land, and in lieu of that free land, they had earmarked 10% or X number of beds for below poverty line patients. What is the evidence on that? If we can actually get down into getting the data for that, frankly, we will have the answers to all the problems we are envisaging in terms of the PPP for district hospitals moving, in the future. And this is a big step. There is an attempt, for good reasons, despite the fact that Sujata might disagree. Public hospitals in the country, in some pockets, have delivered. In many pockets, they have not. The issue is now, what can we do to improve performances there? So you know that the Niti Aayog is pushing to basically open these for, particularly in the NCD area, to private hospital. But my point is, let us consider the existing data of PPPs of our super specialty hospitals, because the understanding is exactly what we are trying to promote now in terms of the PPP in the district hospital. What is the occupancy rate of these 10% of BPL beds? What is the payment system? And you can't just blame the hospitals. You can't say that they don't want to take care of these patients. What is the delay in the payments? The government almost always delays payments, and that is one of the reasons private hospitals are not jumping to the opportunity of getting into these PPPs either. But vis-a-vis the district hospitals that we are talking about, it is important to recognize that there are very large fixed costs in healthcare. It is not like any other business. Entry barriers are there. It is not like anybody can overnight start hospitals. You need, and the biggest constraint is HR, is qualified doctors. Now, the way the PPP has been talked about is in terms of there will be steering committee, monitoring, evaluation, everything done by the government, which is assuming to have enough capacity in a dynamic sense to really have that kind of information. I find it a little naive because the government over the past has not shown that kind of capacity. So constantly monitoring and evaluating what the nature of these key performance indicators will be over time, it's a bit tricky. We really have to simplify the nature of these contracts themselves. Now, given that HR is the biggest constraint, doctors and nurses and so on, they're not rushing to the rural areas. You have to do something to get them there, and the obvious something will be, one is compensation. So in terms of high-powered incentive, what we call in management, that is easier to do, not necessarily going to work here. Because the surrounding facilities, their kids need to go to schools, they need to have other forms of entertainment, quality of life is something. How do you make up for those things? Increasingly, if you think private sector is going to pay more to doctors to move to rural areas, it is also going to put a burden on their margins. Now, if it is going to put a burden on their margin, if they are indeed going to get super specialty specialists to the rural areas, there will be cost cutting naturally. And the cost cutting will definitely happen either in quantity of care or quality of care. So these are not obvious quick fixes that we should be rushing towards. Then the C-section example tells you that key performance indicators, while we believe we can estimate and we can come up with 12 indicators and we'll say, you're doing well, so we will clear your payments, you're not doing too well, so we will scrutinize further. We know that the nature of incentives in the private and public are going to be very different. The key performance indicators, therefore, are not in a position. After all, 41% C-section is alarming to some, but to others, perhaps you can justify that the requirement was such. Now, again, those are things we should be worried about. Equipments and price control. We've been rushing towards price controls. And as you have seen, the stent price control happened. And obviously that price difference is not being passed on to the customers. It is so naive for us to expect the hospitals to pass on the margins to patients. They're not in the business for doing good. That is the nature of business. Right? Now, of course, we can have a separate philosophical discussion on how much profit is too much profit and so on. This is not the first social enterprise we are trying to assess. But it's important to recognize that the only way out, we should be a little wary of price controls. The real long-term fix to these problems is promote many more such businesses that can create these kind of medical devices. Why can India not become that hub? Particularly if you have such a big push to make in India, we have a push towards ease of doing business in healthcare and so on and so forth. Let's promote competition, more firms that can build devices that can then lower the prices of this rather than artificially distorting the market, which we know is not sustainable in the long run. So it becomes perverse, and the perversion will come out in all kinds of problems. So I want to basically end with that. I can take questions pertaining to any of these in the Q&A session. Thank you.
Thank you, Shamika. And so we have had 3 presentations on this. The floor is open for any questions.
It's not the end of the day. After this, we have a lecture also by Pradyumna Rao, but this is the last technical session of the day. It's politicizing health policy and public health services in India, Brazil, and Canada. Now, in India, particularly those of us who see ourselves as the metropolitan elite, for us the word politics is a bad word. So we always like to have policies, but we don't like politics. And we always keep talking about depoliticizing things. So we've depoliticized fiscal policy as an example. We think we have. Everything you say, people say, "Theek, but keep politics out of it," as if former Marxist, all of us when we were in our teens were Marxist, politics is actually a very good word in the sense that what drives the society, the decision-making process, what is your goal in mind? Because you're developing policies, even in day-to-day life, you're keeping some goal, some objective in mind. You have some methodologies in mind. These things I will do, these things I shall not do. We draw red lines. To do all that, setting the vision, setting the methods to do so, so therefore both the strategy and tactics definitely have to be political. And I think one of the things which has happened from what we've listened to people talking earlier on is that we have let individual politics come in the way of a grand political vision of health in India. My understanding. Of course, Canada is different, Brazil is different. We all have our own these things. So let's start with Poonam Mutreja, she's the Executive Director of the Population Fund of India, PFI, an old institution, very vibrant in this field. She's been involved for more than 30 years in the social development sector. She has a master's in public administration from the Kennedy School of Government, KSG. She's worked as a country director for MacArthur Foundation. She's been innovator in various fields, social justice, Shruti, Dastakar and crafts, on leadership, the Ashoka Foundation, and women's health and other issues. 14 to 15 minutes.
Okay, thank you very much.
Because we have 4 speakers and an hour and a half to go.
A 2 minutes warning would be very helpful, sir. So I couldn't agree with you more when you say politics is a good word, and I believe investing in health is good politics. And to quote Gandhiji, health is a country's wealth. So it would make good politics to have a political commitment to health. But what we've done a lot of is politicization of health often. I'd like to use 2 examples from the current situation and the earlier situation, earlier political situation post 2013 as from good politics as well as one example of really bad politicization and politics. What I am talking about and what I thought I was expected to talk about was political commitment. And when I say political commitment, it's not about technical prime ministers making statements or political leaders making statements or rolling out schemes. I always say we are a very scheming society. We keep rolling out schemes. But do we put the money? Do we look at the management? Do we look at the human resources? We look at all of what you're talking about, all of this morning, and especially the last session, which unfortunately I missed, but had a very heated, I believe, discussion. And the one question, let me begin with there, when I ask questions, I'm going to ask more questions, but perhaps some answers too, is does the government have the political commitment? If I was there, this is what I would have said, to regulate the private sector. And Sujata has answered that with a strong nod, we don't. But what will it take to create, to do the advocacy, to build the evidence, to create that political commitment, to convince both the private sector and the public sector that it could be a win-win situation if we had regulations and other things in place. So I refer to the example. Now let me refer to the whole India bringing down its maternal mortality and child mortality over the last 10 years, and several years of that, Sujata, you were the Secretary, Health. When MDGs got rolled out globally, India said it is not a convention we've signed with the UN, we don't accept MDGs. But I believe in this case, the UN system did a pretty good job of advocating for the implementation of all 8 MDGs, but the 2 MDGs that got huge attention politically, globally, and in India, to come back to India, is MDG 4 and 5. Yes, we had the advantage of learning from HBNC. We had the advantage of, which is the newborn, no, I'm saying it wrong, initially newborn healthcare. The model that Serge Gadchiroli, Dr. Abe Bang, and Rani Bang had rolled out, which was scaled up. But that's not the only part of the story. There was political commitment when our Prime Minister said there is a shame, there's a national shame we should have to the looking at the child mortality and malnutrition. The money, the government not only made political statements, but put their money where you need it. So the NRHM, which at the cost of neglecting many other health issues, including NCDs, did invest solidly in MDG 4 and 5. And if you look at the data, every 2 years we saw a huge decrease in maternal mortality and child mortality. And the example I'd like to take of the current government, it required a lot of courage, I believe, for more reasons than one. And again, I'm sorry I keep, reference point is Sujata Rao here. She did advocate very strongly with the Niti Aayog to dismantle MCI. Yes, you did. You can't get sacked anymore. Many secretaries have got sacked for supporting, for being against MCI, which had become an absolute political body to make money, from appointments to make money from government seats and so on. Now, where do they take it? Their political commitment will only be measured where Niti Aayog finally takes where MCI to. But the one example I'd like to take thereafter is the politicization of an issue. When India got its independence, one of the strongest health strategies, which Bhor Committee perhaps had not focused on so much, and yet we had tremendous political commitment to family planning. We had the first family planning program in India, but what did we do to it? I want to take the example of politicization. 1997 took us back many steps by the coercive elements in the family planning program. Now, if you look at, if you want to do tick marks, there's huge political commitment. We have the Population Development Council, which is commissioned, which is chaired by the Prime Minister. We set up a 100 crore fund with Jansthirtha Kosh. We are constantly talking about how every problem of India is to do with our numbers. You ask the health minister why we aren't able to provide services, he or she will blame population. You'd speak to the education minister, bureaucracy, anybody, we blame the population issues, but what did we do? We invested. One is political commitment means you also put the money where you identify a priority. Our budgets for family planning are abysmal, and if you do it, it's very difficult to even find out 85% of our, not the budget, the expenditures, I beg your pardon, 85% of our expenditures are on sterilization, one method, which is the terminal method. And India's population momentum is fueled by 70% young population that we have at the reproductive age group who should be in school and colleges and not girl childs not having childs. We have 85% of the expenditures on one terminal method given the population dynamics. Second, we have 87% of the expenditures of this 85, I'm still sticking to only sterilization, 87% of the expenditure on sterilization is on incentives. No country in the world gives incentive for family planning except India, and there is one more country. I forget the name of the country, a small country. In fact, if anything, incentives are given by many developed countries to reverse the minus growth rates that are taking place in much of the developed world. Now, we have 15% budgets left. Of this 15%, 13.5% of the budgets are on equipment and salaries. And guess how much we spent on spacing methods, which is what India needs, 1.5%. And we are a country with 5 methods, while all our neighboring countries, I refer to Bangladesh, China, Sri Lanka, Nepal have 7 to 8 methods. And there is global evidence to show every time you increase a method, use of family planning goes up by anywhere between 4 to 12%, depending on the efficacy of the contraceptive. Now, all we have done is to politicize, we've demonized not just the issue that these number of people that India has is responsible for us not being able to provide health, education, infrastructure, whatever you need. Second politicization we have done is we have blamed women of this country, and especially the poorest, for having large number of children and desire to have unplanned pregnancies. Now, one place where the government has data, and it was mentioned in the session earlier by by Sujata Rao when she was sharing the different database we have, data sets that we produce, NFHS being one of them, which comes regularly. And NFHS data is, you can criticize them for the fact that there's more demographic data and on issues that we're covering under population issues or family planning issues. Why couldn't we make a plan? Why couldn't we put the investments accordingly? So it's just been, the whole issue has been totally politicized. And that's something we have to analyze, stay away from. If we talk about political commitment, or even if you look at politicization more positively, one of the biggest challenges in politicizing health as an issue, unlike Canada, Brazil, many other countries where elections are fought on health issues, America, where do you see the debate on health being part of our political process, whether it's elections, later it's only demonization? And one of the big impediments is that public health is only for the poor. Unless public health services are used by the middle class, the better off, unless the bureaucrat who also goes to, and all government officials and political officials and machinery goes to the private sector today. How is health ever going? Anything that's for the poor is poor quality. So if you want to increase quality, you want to increase quantity, equity, and so on, you have to, we have to rethink, and there was talk about paradigm shift in the morning. Can we go back to instead of the federal system, health being a concurrent subject, are there politically bold issues we can put on the table to politicize or bring political commitment? Political commitment to health means really investing in not just expenditures on increasing budgets, but the efficacy of current expenditures. It's a catch-22 situation. What comes first, chicken or egg? We keep saying there are unused budgets, so we cannot invest more. But let's look at the causes. Unless you do your diagnosis right, how are you going to do your treatment right? Second, accountability. You know, there is no way, unless there is accountability from top to bottom. One is accountability at the grassroots level, bringing public back into public health. And I do believe NRHM, as part of its design, has mechanisms for accountability. Now, community accountability, well, I'm very proud it's been outsourced to NGOs, and PFI has the privilege of being the secretariat for the advisory group in community action, but it is real outsource. The government doesn't really promote, engage. What is our budget? Do you know, PFI subsidizes the government of India to do accountability. Our budget is 1 crore, and we've already covered 250,000 villages. We've covered 3/4 of the country. Is it possible to do it with 1 crore? PFI subsidizes it. But the good thing is that we work with the government, at least at the state and district level. But is there a political commitment? Is there a commitment within the ministry or within the government? No. I have never heard, starting with political debates in elections or others, do you hear those of you who especially work at the primary healthcare center level, people from government, people from NGOs, with the exception of 6 health ministers, yes, went and spent 3 days in Gadchiroli a couple of years ago, which has great inspiration for them. Do you hear of MPs when they go to their districts, going to their primary healthcare centers, talking to ASHAs, talking to Anganwadi workers? It probably is a rare phenomena. So if you want to make political commitment a reality, first you have to engage, the political leadership and the bureaucracy has to engage, not just in common review mission, but go to the grassroots and see what is happening, ask questions. The 2 people on whom a lot of burden ultimately for service delivery lies is with the ASHA and the Anganwadi worker. What commitment do we have to them? These are the 2 people who are the lowest paid based on incentives. If we really want to show political commitment to those who work in the trenches, let's give them a salary. We keep saying they'll get unionized, they will they will go on leave and so on, but what about the rest of the country? Why make an exception in these 2 cases? So I do believe that political appointments, wrongs have to be corrected, and instead of politicization, let's do political commitment to the health sector.
Thank you, Poonam. Let's go from one end to the other end. Now request Dr. Donald Philippon. He's Professor of Strategic Management and Health Policy at the University of Alberta. He's been in the government. He's been an Assistant Deputy Minister in Saskatchewan. He's been an Assistant Associate and then Deputy Minister of Alberta Health. He's chaired various committees, Central Health Authority, consultant on the transition of the blood system, certified member of the College of Health Executives. So you can see that he's a very richly academically as well as on the government side. Don, over to you.
Well, thank you
Your
for
15 minutes.
giving us opportunity here. And as of last week, I didn't even know I was coming here, so I'm filling in for someone else who could not be here. But you'll see from my presentation that I prepared it with him, so I'll get this up here. Yeah, that's mine. So first of all, in coming here, I realized in talking to you how different the context is. And I wondered, what really can I even share with you that would be of any value? I mean, it's such two different worlds. So I got a slide, a picture of what India was, and you know all about this more, but I needed for myself to get my head around it. The size of your population, the population density compared to Canada, it just, how can we, sure, we are both federations. You have a federal or central government, as we do. We have 1 and 10 provinces and 3 territories, but that's kind of where the similarity ends. So when I look at Canada, we're 36 million people. You're compared to your 1.3 billion. A land mass, we are 3 times the size of you, land mass, but population, you're 382 per square kilometer, and we're 3. I mean, it's just mind-boggling in terms of how we could talk about it. But I guess, and until a few minutes ago, I didn't realize I was speaking twice. So I'm going to try and make 2 presentations out of 1. And on this topic, politicization of health policy and public health services, I mean, there's no question in Canada, health is very much a political. It's regarded as a political endeavor, but I don't think that's seen in a negative way. It really engenders a lot of public debate, and as the previous speaker has said, maybe you don't have that in India, but in Canada, in elections, I mean, a lot of talk is about health care. And politicians know that when they tinker with the health system, they're tinkering with their political future here. So it's very much part of the Canadian identity that health system is a public system, and yes, as a public system, it is under the control of the politicians, and they are there to steward that system. So basically, we have federation type of government, Constitution Act, 10 provinces, 3 territories, and the roles of the federal government and the provincial governments, we use province, not state, have evolved over time. Certainly, the provinces, and that's why listening to your discussion today is very different. I mean, and certainly in Canada, the provinces are constitutionally responsible for health care. As I said, we have 3 territories. Now, remember, these territories I'm talking about, they're huge land masses, but the 3 of them together have less than 100,000 people. So, I mean, it's again, to put it in your context, it's very difficult. And constitutionally, the provinces are protected in terms of their role in health care. The territories are not. I mean, that is something that the federal government has really granted them the same rights to provide health services as provinces. That doesn't come from the Constitution, it comes from the federal government. The federal government, though, has a major role. It sets national criteria to receive funding. It transfers funds to the provinces, and it has direct responsibility for certain groups like registered indigenous populations. So the reality is in Canada, we talk about a Canadian health system, but in effect we have 14 systems. We have the 10 provinces, the 3 territories, and the federal government itself, for some of these groups, does run its own health services. And that's all held together by a whole series of arrangements that I will try and elaborate on here, that I think makes the politicization, if I can use that word in keeping with this session, more acceptable and more understandable in terms of the work within these structures. So one of the problems we have, and I'll say more about this tomorrow in the second session, is that our system was set up by, first of all, focusing on hospital services and medical care services. And to this day, that was a major strength, but it's also become a major liability for us in terms of there's not enough emphasis on community health, there's not enough emphasis on the other social determinants of health, and a lot of the issues we're dealing with are because we've so much ingrained hospital and medical services in our healthcare thinking that's kind of shaped our system. So the Canada Health Act that I'm sure you may have heard about, I mean, it replaced the previous 2 acts in 1984, and it sets in these national criteria for conditions you must meet in order to receive money from the federal government. And also, it's a public system. There can be no extra billing by physicians or no user charges by hospitals. And if there are, the federal government can withhold money or penalize the provinces. So the ideas or the values that sort of hold it all together are these national criteria that the federal government holds provinces responsible for. So public administration, there's a single payer system for health services in each of the provinces. Now, that doesn't mean that they can't contract with from private, because most of our physicians are private providers. But they get all of their payments come from the provincial government. Comprehensive, all medically and necessary insured services, medically and hospital services are insured. but as I said, that does not include a lot of other things, community mental health, things of that nature that are not part of that. Universality, all residents are covered on uniform terms and conditions. Portability, if you travel from one province to the other, you're covered. If you move, you're covered. And accessibility is based on your medical need, not on your ability to pay, so therefore there can be no extra billing or user charges. So the system went through kind of 4 eras. The first era, I say in the 50s and 60s, we really expanded hospital and medical care, covered those, I should say, we made them available to all residents of the country. And initially it was 50% funding from the federal government and another 50% from the provinces. That has since changed. I'll say more about that later. In the 70s and 80s, we expanded it, and a lot of provinces, because of their different wealth, were able to take on other things, so we had different programs develop, and that's why there's a bit of a patchwork in Canada today. It's not uniform throughout when you go beyond hospital and medical. In the 90s and the early 2000s, we really did a lot of work about governance. So with each province, regionalization became the real catchword, that basically all health services would be handled by a health authority, and that has evolved over time as well. And since the mid-2000s, the focus has been on operational efficiency, better access, and improved quality. So somebody talked this morning about process improvement, trying to find how we can improve the efficiency and effectiveness of the system. So I'm going to talk about these 4 features that I think are critical to understanding the politicization of healthcare in Canada: the governmental roles and structures, the funding, the intergovernmental structures, and the pan-Canadian organizations that hold it together. So at the federal level, you have a Minister of Health, you have a Health Canada, you have a Public Health Agency in Canada, which looks after disease public health surveillance. And we have a number of regulatory agencies at the federal level in terms of food safety, health product safety, and patent and medicines. And we have a number of research and data organizations, Statistics Canada and the Canadian Institute for Health Research, bring together a lot of that expertise. At the provincial level, we have the Minister and Department of Health. They provide policy direction setting. They also provide funding directly for physicians. So physicians usually are billing fee for service, but they're billing to the provincial plan. And most provinces have targeted drug plans. Usually they're for low income. They're usually for seniors. It's a big issue in Canada right now. Pharmaceutical policy is an area that's under a lot of discussion. There's a lot of talk about the need for a national pharmacare program, which we didn't do when we started. And as a result, we have a lot of the dynamics you're talking about here about privatization creeping in, because so many of people in Canada think they've got a very good drug plan. It's all through the employee benefits. But if you look at together, if you put it all together, you'll see we're spending a lot of money on drugs in the country. And as soon as you don't have that employment anymore, you're no longer with coverage. So you have a lot of people not having access to it. Within the provinces are health authorities, and they provide the services. They can direct provide it, or they can contract it. And within each province is regulatory agencies on health professions, the scope of practice, competence, and discipline. All the health professional training for physicians, nurses, and other allied professionals are held at the provincial level. And each province now has some form of health quality council, arm's length from government, that kind of monitors the quality of healthcare in that province. 70% of the funding in Canada is, now first of all, put this in perspective, I keep hearing these numbers today and I'm having a hard time figuring what's going on in India, because we always talk about what percent of the gross national product we're spending on health. And that's about 11%. That's a mixture, of course, of private expenditure and public, but 11% of GNP, and I'm still not sure I understand. I'm gathering it's around 6% in India, public and private together, around that? 5, okay. But if you look at our 11%, 70% is public funding. And basically that's general taxation, sales taxes, and there are some premiums that are charged in 2 provinces. In private funding, you can see about 14% is out of pocket, 12% is private insurance, usually for drugs and for dental. The federal government then transfers funds to the province in 2 respects. One is the Canada Health Transfer, which evolved from, I said before, it was 50-50 cost sharing. Now it's a per capita amount, goes to each province. And secondly, equalization, which was a formula brought in the 50s that would say, understanding that the tax base of different provinces was different. So they would compensate provinces for that. That's not necessarily directed to healthcare, but that's a major source of money for the provinces. But at the provincial level, and here's where I think a major difference is, 40 to 50% of every provincial government's budget is health. So when you think about India in terms of what you spend on health, I mean, 40 to 50% of the provincial government money goes towards healthcare. Now, what holds it together? There's these 14 systems, I said. But first of all, the First Ministers' Conference, they meet at least annually, sometimes more frequently. It's the Prime Minister and the Premiers. There's a very formal structure called, I'll jump to the third one, the Conference of Ministers and Deputy Ministers of Health. That meets twice a year. There's a whole series of subcommittees that go below that. And certainly as a former Deputy Minister of the province, I chaired that committee for several years when we bring all these things together. In fact, I just had the last meeting last week when I was in Edmonton. We also have an organization called the Council of the Federation, and that is strictly the premiers and the territorial premiers, regional territory, they get together without the Prime Minister there. It hasn't had the same kind of impact as the other organization, but it's still a major part of our structures. Another thing that I think is critical to what keeps the Canadian system together is probably since the late 80s, the development of these pan-Canadian health organizations that are looking across the country, across provinces and territories. So we have one on substance abuse and addictions, drugs and technology and health, and you talked a lot about data. We have a very good organization called the CIHI, Canadian Institute for Health Information in Canada, that pulls information from all the provinces, publishes it annually, shares it. You can go in there, you can do a deep dive on any one area of the country and compare it to others. Certainly, as you've talked about here, we have data problems as well in terms of what gets entered, but I think it's come a long way. It's not perfect, but we do have the capacity to compare what's going on across the country. And we have a whole number of these other organizations. I won't go through the whole list, but the idea is that it's a way for us to kind of look at how is the health system going across Canada that's kind of away from each individual province or the federal government looking at it. It provides an overall picture of health services. I might add, and when I went through this very quickly at the beginning, as you probably know, we are a bilingual country with 2 official languages. So the province of Quebec, with about 8 million people, is a French-speaking province. And it has, in fact, on many of these aids, is not part of some of these things, okay? So there's that difference that exists in Canada. Maybe just to finish, and I must be getting close to my end of my 15 minutes here. We talked about how this all works in Canada. So if you look at the funding, administration, delivery, so the hospital services, diagnostic, or public taxation, general revenue for governments, that's how it's funded. It's administered through a single payer system I told you before, but basically it's self-regulating private professionals that basically provide the service. We have things like prescription drugs and home care where there's a mixture of some public funding and some private. And of course we have other things that are strictly private goods. Vision services, dental, and so forth are largely private services. So that's kind of breaks it down in terms of the different levels of order. So I guess I'm not sure I'm totally meeting the theme of this session, but it gives you a sense of it's very much a political thing in Canada, but we have a number of structures and a number of ways that we deal with it that hopefully provide more of a context for how we handle it. Okay?
Thank you, Don. Thank you. In fact, the legal constitutional arrangement that you mentioned between the federal and the provinces, in fact, when we drew up a constitution, we took a lot from the Government of North America Act 1867, which is your basic constitution. And don't fall for his 3% per square kilometer. If you remove that 100 miles touching the US border, anything above that is zero.
Right.
So all of it is in that narrow band, extremely narrow band.
That's right.
And yes, your equalization is again, our finance commission is the way we have taken on the federal transfers to equalization. So there is obviously a lot to have learned from Canada. Now let me jump back to India. Our next speaker is our chairperson of the previous session, Dr. Abhay Bang. I heard his name first, search Gadchiroli. No, I don't search for Gadchiroli. Gadchiroli is very much there. But the institution that he set up with his wife, but basically concentrates on obviously tribal people living there, but the education part and the research part. In other words, getting the context right is so very, very important. He is now the chairman of the expert committee for tribal health appointed by the Government of India to frame the first tribal health policy and recommend design. He is also advisor to the state government on these issues. Committee under the chairmanship of Devendra Fadnavis, Chief Minister, to effectively implement the ban on alcohol. He is also a member of the Central Health Council. So he is very much part of.
Thank you. Please be seated. Please. I'll stand from here.
Okay,
That makes-
okay.
Okay, thank you very much. And thank you.
So your 10 minutes starts now.
Yes.
12 minutes, 15 minutes, sorry.
Yeah. Now, I'll take little liberty. No, I think my voice will be adequately loud. I'll take little liberty and I'll be trying to address in my presentation not only the title of this session but also both title of the conference, improving public health care through fiscal federalism, but also some issues, political issues. Again, I'll be touching not everything, but as you can imagine, everything cannot be covered in 15 minutes. So I'll be covering only 3 specific small points. Federalism beyond the center state. Ensuring allocation for the weakest. That is the most important politics of health. How to harness the power of prevention, both for improving health as well as for mobilizing money. Usually we consider prevention as the most sort of unattractive piece in healthcare, but so, and instead of trying to talk from the macro level of which I am not the expert, let me take you and I am going to really adhere to mostly experiences and data from one district, Gadchiroli. Now this Gadchiroli is in Maharashtra state. For our friends from abroad, Maharashtra is probably economically one of the most developed state in India. At the extreme other end of Maharashtra state is this small tiny red district. It's red in both senses, though I am showing it red here, but it's also left-wing affected district, full of Naxalite activities, and district has got 1.1 million population. 39% of the population is tribal, indigenous population. Poorest district, or maybe second from the bottom in Maharashtra. So in this developed state, there are some districts which are undeveloped. And Gadchiroli is one of such states. As I said, that's why it's also affected by Maoism. Now, it's not alone. If you look at the economic and political development in India is uneven. There are about 200 districts in India which are similar to Gadchiroli. Lack of economic development, politically weak, a large proportion of them are affected by Naxalism. So, depends on what cutoff point you use, but Planning Commission had identified nearly 190 districts. So, almost 1/3 of India. So, the situation in Gadchiroli is similar to the 1/3 of India, and maybe also lakhs of villages in India also are similar to Gadchiroli. So, I am going to really begin. The challenge is really, challenge number 1 is how will the fiscal federalism in health involve these mini and micro levels of governance. Usually we think only about from center to state and that's it. From Delhi, only state capitals are visible to us. But in a state like Maharashtra, there can be Gadchirolis where development doesn't reach. And within Gadchiroli, there could be hundreds of villages. There are 1,500 tribal villages in Gadchiroli where nothing has reached. And so our federalism principle has to percolate down to the level of districts and villages. And so, not only that is challenge before us, but actually the Constitution of India provides us the solution. Constitution of India, either original Constitution or the subsequent constitutional amendments done in 90s, the democratic governance structure goes beyond the state capitals. We have at district level, Zilla Parishad, we have at Gram Panchayat, a cluster of villages constitute Gram Panchayat. And through Panchayat Raj Act, we have recognized them as third tier of governance. And then there is another constitutional amendment by the act called PESA, Panchayat Extension to Scheduled Areas. This principle of federalism extends, or principle of democratic decentralization extends up to the Gram Sabha. Remember, Gram Panchayat is different and Gram Sabha is different. Gram Panchayat is usually of 5,000 population, but within 5,000 rural population there could be 15 tribal villages, which could be 40 kilometers apart from each other in forest. They can't assemble together. So Gram Sabha, PESA Constitution Amendment recognizes Gram Sabha as the democratic political unit of governance. So the challenge is, how will our fiscal governance not only address distribution of money within states but also to districts, because otherwise 200 districts will be left out. They don't have political voice in the state capital, and lakhs of villages will be left out. So this is the one challenge, that at the policy and planning level we must include these three. My second question or second challenge before us is how to ensure allocation for the biggest political question. And when it comes to health, that weakest is tribal in India. Gandhi once gave us that very well-known talisman that when you are faced with a dilemma, bring before your eyes the weakest, most miserable and powerless human being that you ever saw in your life. And ask yourself, the step that you contemplate, will it help him? For the public health policy and planning, that the weakest, the talisman that Gandhi provided us is tribal. Tribal health, and just for those who have not seen, actually it's mainly for the friends from abroad, that tribal in India, there are about 700 different tribes in India. The total tribal population in India, you will be surprised to know, is 3 times the total population of Canada. 104 million, and that was in 2011, so it must have become about 110 million by now. 1/3 of the global tribal and indigenous population lives in India. 8.6% of India's national population is tribal. And last year, on the invitation of Lancet, we and a similar group like mine, we reviewed the tribal health world over. We could get data only from 23 countries, but this global review of tribal health was published in Lancet last year. But I'll share only one finding, and that is IMR of tribal population in India, it is highest in the world, next only to Pakistan, not to be very proud of it. India's tribal IMR was higher than any other IMR of any other tribal population world over. At that time, when we made that estimate based on 2011 census, the tribal IMR in India was 74, while it is at the level of 3 to 5 in developed countries, tribal IMR. Tribal people have the worst health status. They have healthcare in tribal areas is very weak, quite well accepted. You don't need an expert committee to establish that. But healthcare to the tribal people is the acid test of equity and social justice in India. So when we are thinking about public health in India, we usually look at it at women's health, children's health, and so on and so forth, or disease-wise. But the tribal population is one section. And so Government of India constituted an expert committee on tribal health in 2013. Assumption was that the NRHM and the rural healthcare pattern is extended to tribal areas as such, except for little tweaking of the population ratios, assuming that the tribal healthcare is same as the rural healthcare. But Government of India realized that probably this is not working, and so this expert committee was appointed jointly by Ministry of Health and Ministry of Tribal Affairs. I am the chairman of this committee, and report will be submitted by the end of next month. This is October. By end of November, we will be submitting our report on tribal health. But I'll touch only one part, especially because we are talking about fiscal federalism. Planning Commission guidelines that each ministry, both at the center and the state, except for defense and ISRO, etc., but each ministry at the center and the states must allocate and spend a percent of its budget equal to the proportion of ST population. So Health Ministry, Government of India must spend 8.6% of its budget on tribal health. Madhya Pradesh, suppose Madhya Pradesh, I don't remember exactly, but suppose Madhya Pradesh has 30% tribal population, 30% of its health budget must be spent on tribal health. These are Planning Commission guidelines. And then in addition to that, out of the planned budget, both at the center and the state, Ministry of Tribal Affairs gets the same percentage of the planned budget. It's called tribal sub-plan. Like there's a sub-plan for SC, there is a sub-plan for ST, tribal sub-plan. Which means actually at the policy level, we have made adequate provision that the tribal health should be financially ensured to get that share. Question is really, just an example, Ministry of Tribal Affairs in Maharashtra annually gets about 6,000 crore rupees of the planned budget alone for tribal health. And 15% of this, by its own guidelines, MOTA's guidelines in Maharashtra, 15% of this must be spent at the district level on health. So, there are adequate provisions really, policy provision for tribal health to be financed. Now the question is, well, our committee has been trying to investigate what actually happened. How much of this share was actually allocated and spent for tribal health? How much money is needed for tribal health? And how to ensure the rightful share that the tribal people and within tribal life, the health sector in tribal health needs. Now, I don't think I am entitled to divulge the main findings of the committee here, so I would only say, wait for the report. But these are some of the questions this committee has tried to address almost for the past 4 years. It's very painful to realize no data exists on tribal. You'll be surprised. In this room I can share this, that Ministry of Tribal Affairs, Government of India, which constituted this committee, could not give us how much is money spent by states, different states on tribal. It has its own guidelines that equal to the tribal proportion of population money should be spent, but MOTA doesn't know. So, the report will cover several of these points as well as what could be the suggested structure of delivering tribal health, structure of human resource, finance, governance, and current diagnosis of tribal health. I come to the third point, and I will be a little brief now. Prevention is always looked at something nobody wants, and all the heated discussion was on curative care, which touches everybody's life. And so it is usually assumed that the prevention doesn't have any political mobilizing power. I actually, in my small experience of last 40 years of working in community health, I find that curative care appeals enormously to individuals and families, but not to the communities as a whole. It hits you individually. One who falls sick, he immediately feels its need. Preventive issue really cuts across, and they appeal to everybody. Though they may not appeal very powerfully, but they touch everybody. So one of the issue I am going to talk is how to reduce consumption and harm caused by tobacco and alcohol. Most unfashionable topics, but the global burden of disease study has now recognized that tobacco and alcohol constitute one of the 10 of the topmost public health risk factors in the world. How to reduce this? Because with the emergence of non-communicable disease epidemic in India, preventing these two, consumption and the harm, has become very important. Case of Gadchiroli. Now, tobacco ban Government of India has introduced COTPA Act in 2003, by which tobacco sale of various kinds of products to sell to children near the education institution. There are several bans. Government of Maharashtra introduced a ban on scented and several forms of tobacco in 2013. And on alcohol, actually Government of India's policy, national policy about excise policy for scheduled area prevents any state government for permitting any trade of alcohol in tribal areas. So actually, policy-wise, both tobacco and alcohol are banned in Gadchiroli. Now search, my organization has been conducting district sample surveys of Gadchiroli, similar on the lines of NSSO, but much more intensive sampling in collaboration with the university, Gondwana University. Annually we are doing surveys. So now let me share, and the findings only on the out-of-pocket expenses on tobacco and alcohol. Out-of-pocket expenses on tobacco and alcohol as purchased by the people, as they themselves given data as to how much money did I spend on tobacco and alcohol. Now remember, when you read those numbers, remember the population is 1.1 million. So this expenditure applies to 1.1 million population per year. Alcohol, in 2015 survey, we found 79 crore rupees spent on alcohol by people, by their own admission. Tobacco, in 2016, next year we included tobacco, 293 crore rupees spent in 1 year. Total, 372 crore rupees spent. Now just for comparison, let me tell you, the total annual developmental budget of Gadchiroli district is 157 crore rupees. So people are spending more than twice the amount that the government is spending on development of the poorest district in Maharashtra. So our hypothesis is that reducing tobacco and alcohol consumption will not only improve health, but it will reduce poverty. And this is the alternative way of reducing poverty. And so we launched a district pilot by name Mukti Path. The subtitle is in Marathi, Daru आणि तंबाखू मुक्तीच्या दिशेने, towards liberation from, I am saying towards, we know we will never achieve 100%, so towards liberation from alcohol and tobacco. The goal is to reduce prevalence of consumption by 50% and out-of-pocket expenses by 33% in 3 years. We know this is a difficult challenge. People don't quit tobacco or alcohol so easily. It's a difficult challenge. There are a lot of trade and economic vested interests involved. In 3 years, we hope to achieve this. Remember, reducing by 33 crore rupees in 3 years would mean about 125 crore rupees per year saving for Gadchiroli. That is the goal. 4 partners, Government of Maharashtra, and Chief Minister has accepted the chairmanship of task force which has started this project. When I put this argument before him, the whole argument of Gadchiroli and idea of this kind of project, you can imagine Chief Minister will not be very much mobilized by tobacco and alcohol reduction. But he was moved by the argument that poverty will reduce. People are spending 372 crore rupees and all government schemes put together, the amount of economic benefit people get, this particular intervention will give more benefit. That was the argument he was convinced by. And so the 4 partners, Government of Maharashtra, Search, my organization, Tata Trust which are funding it, and the people of Gadchiroli. And so this is the structure for this project. State level task force with Chief Minister as the chairperson, 5 ministers and 5 secretaries as the member. I am the advisor. At district level committee, district collector, which is district magistrate, is the chairman for implementation, district health officer. We have introduced a new agency called Mukti Path district team. And then taluka level, tahsildar, panchayat samiti level, sarpanch, and then at the village level, gaon sangathan, where village, active people in the villages who want to reduce tobacco and alcohol. Our strategies, we have adopted an integrated strategy for alcohol, tobacco. One is demand reduction by way of mass awareness and de-addiction for those who need therapy. For supply reduction, our emphasis is more on community action to prevent alcohol and ban enforcement by the government. There is already ban, so we are trying to mobilize police department and food and drug for ban enforcement. So village awareness meetings have taken place in 1,500 villages. Women have got mobilized, and women in tribal areas, in rural areas, I guess all over India, one of their highest priority issues alcohol and alcoholism ban. So huge mobilization of women. If you can read, it's a Marathi, but daru bandi jhalis pahiye. Alcohol must be stopped. People are assembling in large numbers. And look, this is the power of prevention. But when you put prevention in economic argument, it has got enormous mobilizing power. In addition to that, the ill effects of alcohol suffered by women are so gross that you don't need data and logic. They have experience in their own lives every day. So actually a grassroots movement for prevention has started in Gadchiroli. 1,800 villages have formed their own Gram Sangathan to reduce or ban alcohol and tobacco. 460 villages have put community ban on alcohol. And every day the local newspapers are coming with stories as to which village has stopped alcohol consumption in the village. And parallelly we are assessing impact through the district sample survey. And the district sample survey 2017 that we have conducted, though I have not put it there in print because we have not really shared that publicly, but just unofficially let me tell you, we have almost, the consumption has reduced by 17% prevalence, and out-of-pocket expenditure has reduced by 70 crore rupees, which is practically equal to the 50% of the district developmental plan. So a promising district level model of prevention of a substance which is not easy to prevent. An integrated approach is emerging. To my knowledge, it is for the first time in India that anywhere integrated strategy of alcohol and tobacco reduction plus government, non-government organization and donor together such is emerging, and Chief Minister has given promise in the assembly that if our experiment here in Gadchiroli Chandrapur succeeds, I would consider it extending to the entire state. But that's a future. I won't get into the future. Right now we are still conducting district level pilot. 2 years are yet to go. So in summary, fiscal federalism needs to include district and village levels also. Fiscal federalism must ensure health care for the weakest sections, and we took the case of tribal health and tribal people. And third, an approach to harness power of prevention is necessary both for reducing disease, especially non-communicable disease, and also for saving money. Thank you very much.
Thank you. Last speaker. We move from Gadchiroli to Brazil. You've already been presented? Okay. So that makes it easier. He has worked at a lot of work is done at the municipal level, I see, at the Câmara Municipal.
Talking again. You are probably very tired now, and this is a very diverse session. Probably we won't have such a heated discussion as we had in the previous. Well, I'm going to talk about some major political challenges that as I said before. Okay, I think those are oh, this is the old one. Oh, this is the old one. That's right. No, okay. It is the old one. Okay, no problem. There's another challenge. Well, SUS, as I said before, was created in 1988. It's almost 30 years old. But we have the first major challenge is the rivalry between the private and the public system. It's a very strong rivalry. I'll talk a little bit about it. And the management of our system was largely transferred to municipalities, the third level of our federation. Brazil has municipalities are part of the federation. So it's something similar to what you were saying, giving power to district level, to village level. And the third problem, there's a fourth, I think this is the old one, is that labor unions never supported SUS, and they fight to get private health insurance. This is incredible, because in most countries where there are public health system, they are supported by the labor unions, by the working class. Like in Canada, it started in Saskatchewan. Huh? It was very a strong labor movement, and all over the world. But in Brazil, it was different because of our political problems. I'll talk a little bit about it. I know you are tired. Well, the SUS, our public health system, is there's a strong drainage of resources by the private interests. During the dictatorship, the military dictatorship that lasted 21 years between 1964 and 85, there was a strong incentives by the state for the private health system. Those incentives were left untouched. The biggest one is a fiscal subsidy. Every cent that one person or a company spends with private health care system is deducted from income tax. So this is incredible. So if I spend $1 million this year, I will get all that deducted from my income tax. So it's interesting for many people to get private health insurance, although most of it is patron-sponsored. Most of medium and high complex services in SUS, hospitals and diagnosis tests, specialists are provided by private contractors, and they are intermingled with our political structure, as we're going to see, in the municipal level. Private or medical health insurance is the first consumption desire of Brazilians, as shown by recent surveys. Everyone wants to get one. Although 80% of the population depends on SUS, and 100% depends on SUS for cancer, for emergency care, for everything that is expensive. 100%. The public system gets the best share because they don't spend much money. When people get old, they leave the system. When they need more the care, they leave the system. It's an incredible thing. Well, SUS was transferred to municipalities. They have the control of it. The idea was that with this move, we would democratize the system. The system would be closer to the citizens. It's not that, because most municipalities are very small. They don't have a complete healthcare system. They depend on the neighbors for that. So, and they compete with each other because they are all run by politicians that want to go up in their political careers. And so they don't want the hospital to go to the neighbor. The hospital should be here, not there. And so they compete all the time. And we don't have regional health authorities like they have in Canada. We don't have regional health authorities. So the authority is scattered, dispersed among many municipalities. In some health regions, you have like 55 municipalities. Imagine an assembly of 55 competitors deciding a common subject. It's a crazy thing. And the smaller the municipalities, the more politically conservative they are. Municipal authorities and private interests in healthcare system are very intermingled. They are relatives. The guy who owns the hospital or the healthcare facility is a cousin of the mayor, so they hire services from their families. And the lack of support by the working class has lots to do with the military dictatorship and the Brazilian situation during the Cold War. The Brazilian military coup d'etat was very important during the Cold War in Latin America, and we followed two American examples. In 1947, in the United States, they approved the Taft-Hartley Act that put a very strong political repression on the left in labor unions. So labor unions in the United States can't be directed by communists, nor anarchists, nor socialists. We got the same idea in 1964. In 1950, there was a Treaty of Detroit. The Department of State negotiated with General Motors so that General Motors would provide a patron-sponsored health insurance for the employees to stop the idea of creation of a public health system. This was a very important political movement. And we followed this example after 1964 in the military. After 1964, we also had a very harsh repressive measure on labor unions. Then there was the creation of public health, private health insurance by law. So there were, and in 1967, they created this fiscal subsidy that lasts for half a century already. And they also decided that the private contractors should have the preference in public health provision of services. So different measures taken in 2 years incentive very strongly the private sector. And let us try to link things. Brazil is a federation since 1889. We were independent in 1822, but Brazil was a monarchy, the empire of Brazil at that time. And it's incredible because it's a union of the states and municipalities. It's the only one in the world. Municipalities are considered part of the federation. It's the only place in the world. Most regional and local governments are dominated mostly by traditional large landowners. This is our geographic situation, the different states of Brazil. The main figures, we have almost 210 million people, 26 states and one federal. I mentioned this before. It was an expansionist federation like the United States. We started in a part of South America and we grew, taking land from other countries, mostly by war. The population and income are very regionally concentrated. The population is concentrated mostly at the coast, near to the coast, and those three regions of Brazil are the richest ones. So the income is there. Since the colonial times, power was held by private interests linked to the property of land property. In 1831, the creation of the Guarda Nacional was a very important for this. It reinforced the power of landowners because they could literally buy a title of colonel of the Guard. And with that, they could organize their own militia and they could influence the nomination of judges, school directors and so on, public officials in general. So that's our municipal council from colonial times. And those are images of the colonels, very rich people, very strong people. I go through this. I'm not going all the history. We don't need that. But during the dictatorship, another major movement was they reinforced this power of regional and local government. Two different political reforms in 1977, 1979, they shaped the current political system we have. And they created first a disproportionate system of representation in favor of those traditional oligarchies. So one voter of Roraima has the power of 12.3 voters in São Paulo, which is the most urbanized and most rich and most socially organized state of Brazil. So a very small, a tiny state with only 500,000 people has proportionally much more power. So the 6 great states of Brazil are underrepresented, and the smallest states are overrepresented. So this explains why our parliament is so conservative. They also made it extremely easy to create political parties. We have 28 now, and 14 have been formed. It's very easy to create political parties, and so power is scattered. It created this kind of presidentialist coalition system, you say. The number of parties in government is always growing up, so people create parties just to make business. It's a very corrupt system. Presidents are hostages of this system and became less and less able to implement national strategies of development. So power is very dispersed. This is a graph I made. We are researching this. The different governments after the military government and the number of parties that take part of it, they don't stop growing up. So power is becoming more and more dispersed. And president can't do anything. They are literally hostage. The first Collor was the first elected president of Brazil after the dictatorship, until Dilma, who was put aside in last year. So it's an ungovernable country. Well, the links with health. SUS is the largest, second largest budget at the federal level, and the first in state and municipal level. The 3 levels of government, they have to jointly finance our public health system. So as it's dominate, as the municipalities became too strong in the management of the system, they control it. Another feature is that because of the number of parties, all the budget, all the investments, all the capital expenditures are dominated by politicians. Every deputy in Brazil can make 25 amendments to the budget project. So it means 25 public works that he dominates. So, and we studied the use of this system in primary health care investment. We organize it by deciles, a group of the municipality, different, we have more than 5,000. And the first decile is made by, composed by 550 smaller municipalities where the poor people live, where the coverage of the service is worse, it gets only 5.7. So the political system dominates the investment. So it's difficult to change the healthcare system. It has an inertia, you know. This is a very important problem. I don't see any solution for this. This is Minas Gerais state, one of the big states of Brazil. It's bigger than Spain and Portugal together. Has around 18 million people, and complex health care facilities are very concentrated in a few municipalities. It has around 853 municipalities, and only a few have cancer treatment, IMI, and cardiovascular surgeries, and so on. So people have to travel 700, 800 kilometers to have access to these services in Brazil. And this, the control of the transportation of people is political also. So it depends on the favors of local deputies, because we have a parliament in every municipality. So it's all controlled by it. So if someone needs a treatment, he has to ask for a favor for the politician. So services are concentrated in few municipalities, and they have to transport people. So I prepared I don't know what's happening, because I'm always giving the old one, but I think it's okay, the idea. So we have, this is the main idea. It's not that a rosy picture. We have big achievements. I'm going to talk about achievements tomorrow, but they are hindered by this kind of political system, a very conservative and resilient political system that came from the colonial times and has been reinforced many times.
Thank you very much, or should I say, obrigado, Senor Paulo Rodrigues. You know, there's an American political scientist, and who's still alive, called Guillermo O'Donnell, who studied Latin America very carefully. If you have the social structure with a strong latifundia, an army, and a strong industrial class derived again originally from the latifundia, and then you make some accommodation to the organized trade union, you form an oligarchy and keep out everybody else. In such a case where you have an elected president and a strong parliament, which can change budgets very easily, then you come up with knights in shining armor who promise everything and cannot get the act through because parliament is not with them. And that is what you've just described. So, you know, you adopt an American system which is designed for failure. The Americans, when they designed their constitution, were very afraid of the executive. So they made full effort to ensure, though America has changed in 250 years, the executive has become much more powerful, but it derives from a fear of the executive. The end result is, as you can see, this functions at a big level. Let's take quick questions, and then what I propose is, immediately after this, we'll continue with the lecture of Dr. Govinda Rao, instead of taking a break, so then we can break for the day. To be followed by dinner, of course, but yes. So, Hadi, Rudraji, to the point? Buzz. Now we have a lot of discussions just now on Canada, on Brazil, on federal transfers. So this he'll be speaking on that. Please take your seats. As we say, please settle down. We can start. Kya hua, main nikal rahe ho? Come back quickly. We'll take a 2-minute. Yeah. What's it called? Pit stop. Pit stop break. Because we have been, financing is an issue. It's not the only issue. Governance is a serious issue. Political commitment is a serious issue. But looking at the figures involved in India, obviously fiscal transfers are an important element.
Good evening, friends. I'm sorry that I had to be standing between you and the dinner. I mean, it's been a long day, and at the end of the long day, to speak about intergovernmental transfers, which is a contentious issue, is not very pleasant. But nevertheless, this has to be spoken, so we will continue with that. And I'd like to thank Shakti Sinhaji and Forum of Federations Canada once again, and of course Interstate Council, for inviting me to this. As I had mentioned earlier, I am not a health expert. I once in a while get into this area from the point of view of financing, and then do some work as required. Of course, I have been working on intergovernmental transfers virtually for the whole lifetime. That has been my bread and butter, I would say. So I'm going to be speaking about this intergovernmental transfers in two different occasions. In fact, one today, and then again I'll be back on second to speak on that. That is for the UNICEF. So though I have different presentations, I think this is much more comprehensive, so I decided to. So I will start with an introduction, and after an introduction I will talk about the demographic and economic and demographic profile of the country, and then I'll talk about the distribution of health expenditures across states. Financing health care, rationale for transfers, why do you need to make intergovernmental transfers? And there again you have general purpose transfers. In the case of Canada, you have equalization transfers and Canada Assistance Plan. Now, like in the case of Canada, we do have general purpose transfers, which is basically given on the basis of the recommendations made by the Finance Commission every 5 years. In Canada, the Department of Finance has, a department that within the department they themselves estimate the equalization payments based on the revenue disabilities of different provinces. In Australia, you have what is called the Commonwealth Grants Commission, which is the permanent commission which makes recommendations. In India, we have what is called the Finance Commission, which has been taken from the Australian Constitution. Finance Commission, which is appointed every 5 years, which makes recommendations for the next ensuing 5 years on the volume of transfers. And over a period of time, there has been a certain amount of clarity that has come into picture. Because earlier, Planning Commission too used to make the grants for plan purposes. Now, and I'll come to that, but then after the Finance Commission took over that role too, by the 14th Finance Commission, there is a clarity of conceptual clarity on the general purpose transfers and the specific purpose transfers, which are basically given by the different ministries through what is called the centrally sponsored schemes. I'll talk about these, and then I'll go into the issue of recent trends in health expenditures, and I'll talk about the major specific purpose transfer in regard to health, which is National Health Mission. Then I'll ask a question: do all these transfers, at least specific purpose transfers, really result in increase in expenditures? I have some results which say that it doesn't. There is a lot of substitution that is going on, which basically means there are questions of design of transfer system. Then, of course, I'll conclude. I'm not going to take a long time. because I think you're sufficiently exercised. I don't want to exercise you more. So let me start with a brief introduction. The global burden of disease study places India's health status as 154 out of 195 countries. And of course, health is a basic right, as I mentioned earlier. Article 47 under the Directive Principles of State Policy states that the state shall, and I quote, the state shall raising the level of nutrition and standards of living of its people and the improvement of public health as among the primary duties. And as the Supreme Court in the Paschim Banga Khet Mazdoor Samiti and others versus the state of West Bengal, and has widened the scope of Article 21 and made it a fundamental right to declare that it is the government's responsibility to provide medical aid to every person in the country. Despite this, we are yet to see the rights being implemented. In fact, in respect of Panchayati Raj, there used to be a very honorable minister in Karnataka called M.Y. Ghorpade. He used to say that we have enacted, but now let us act. And so we have enacted, but we haven't acted. That's all that I want to say. There are wide variations in health status across the country. Life expectancy varied from 64.5 years in Uttar Pradesh to 75 years in Kerala. Infant mortality rate for 1,000 births varies from 47 in Bihar to 12 in Kerala. Wide variation in health infrastructure such as coverage of health centers, health workers and hospital beds, which is a fact, and whole day we have been talking about it. The other important thing that one has to see is that healthcare is essentially in the domain of the state governments. There was some reference to the fact that we need to have, we should possibly think of moving it to a concurrent list. God forbid. We moved education to the concurrent list. What happened? Did anything happen? The medical education, the regulation is with the center. What happened? Did anything happen? Ultimately, healthcare has to be delivered at the local level, at the panchayat level. Of course, we have created parallel bodies. But the point is that, who knows what sort of problem is, sort of important where. And, sitting at Delhi, we all want to centralize. Now, I would have preferred somebody saying that let us move further down, as was mentioned by Dr. Dr. Bang. But anyway, the point that I am trying to make is that healthcare is essentially in the domain of the states. Ambedkar had a problem in the while writing the Constitution. He was against decentralization, particularly to the decentralization below the state level, because one can understand the sort of persecution that one had made in a feudal village. So, I don't want to get into those issues, but the fact of the matter is, today, so I take the Constitution as given, and then, in the healthcare, entry 6 in the state list, which says that public health, sanitation, hospitals and dispensaries. And entry 17 in the state list talks about water supply. And there is concurrent list 26 and 27, which basically say medical education and services. Medical education is in the concurrent list. The fact of the matter is states have this important function to perform, yet they have significant revenue disability, as all broad-based tax handles go to the union government, and states have predominant responsibility for providing social services and co-equal responsibility for providing the economic services, physical infrastructure. Now here again I want to draw a distinction, a difference. In Canada, all taxes can be levied by all levels of government. In fact, you have a provincial income tax, you have a, because I mean, the Supreme Court there had ruled that all taxes on property can be levied by everybody. And so that is the situation. They have, they have harmonized the system well. But in India, you know that most of the major tax handles are with the union government. And the states have most of the responsibilities. And we basically call it a vertical fiscal imbalance. And besides this vertical fiscal imbalance, there is also significant horizontal fiscal imbalance. The state with the lowest per capita income has 1/5 of the per capita income as the state with the highest, not including Goa. Goa has the highest per capita income, and so the next is Sikkim. But if you take Haryana, so which has the 5 times per capita income as Bihar. So you have, the type of equalization requirement in this country is phenomenal, which is not seen in any other developed federations. The difference there is 20% plus or minus. That's that's a significant difference that one has to see. Now this also has an implication. To what extent can you really equalize? Even if the Finance Commission is a technical body, can it make a recommendation to the effect that Bihar gets 5 times per capita the transfers as Haryana? Is it possible? Is it politically feasible? Will it be accepted? These are some of the questions that will come into, because these are the questions that we have had to confront with. Now, wide variations remain, as I mentioned, between the wide variation in revenue capacity among the states, and obviously expenditures across the states, including the healthcare expenditures. So there is a need for a well-designed transfer system, both to offset the vertical imbalance as well as to have since you cannot fully offset the fiscal imbalances through a general purpose transfer, it becomes extremely important that some of the major merit goods, such as healthcare, basic education, poverty elevation, these are sufficiently funded so that the access to these are given. There is, to talk about this distinction between the two transfers, the objective of general purpose transfers, let me put it very distinct, is to enable, not to enforce or ensure, enable every state to provide comparable levels of services at comparable tax rates. That is the general purpose transfer. You are only enabling. You can't force them to do it. You are enabling through, offsetting the revenue disabilities. You are enabling through offsetting the cost disabilities. The objective of specific purpose transfer, unlike in the case of general purpose transfer, is to ensure minimum standards in the selected public service in question. Ensure. So if you are not able to fully offset the general fiscal disabilities, the importance of the second type of transfer becomes extremely relevant, and therefore, and that is the reason why one has to basically look at the specific purpose transfers with a much more serious in a serious manner. Now, if you look at the demographic profile of the state and economic, you will see these are the major states. I have not included the special category states and the small states for an important reason. Because most of the expenditures there have to be paid, sort of made through the transfers anyway. In fact, all, both the general purpose transfers and specific purpose transfers are very liberal as far as they are concerned. And of course, the 14th Finance Commission has not used a different yardstick for them. It used the same yardstick. But then what we did is we took into account a significant manner the cost disabilities in these states by bringing in the forest cover as one of the factors, and that substantially took care of that, because Constitution does not say special category states. Constitution says, doesn't make a distinction between special and general category states. As a constitutional body, we are not saying that the sort of union government, whatever, or the planning commission, whatever they want to do, let them do. But the for them, every state is a special state. For the 14th Finance Commission, every state is a special state, and every state, their fiscal, disability had to be seen. In fact, there was a big controversy on this. In respect of Andhra Pradesh, and the then urban development minister, Mr. Venkaiah Naidu, went on saying that the 14th Finance Commission has said that, we should not, make a special category status, and therefore we are not giving special category status. Subsequently, I wrote an article in Hindu, basically saying that this is misleading. 14th Finance Commission never said anywhere that special category status should not be given. It is your executive decision. We will not make a distinction in our analysis. That's all that we, we did. But anyway, that is different. If you look at the demographic profile and the economic profile, you will see that the states with somewhere about 43% of population have 63% of the per capita incomes. 63% of the incomes. The state with the 40 and then they have a much lower poverty distinction. That means it's in the poor states, the state with 57% of the population has just 36% of the incomes, 68% of the poor, this thing is 66% of the poor, and if you look at the children, if you look at the demographic, transition, if you want to call it, or demographic dividend, staggered demographic dividend, if you want to call it, they have 63% of the children. Now, which basically implies that these states have, when you are talking about health, and these are the states that need to be looked at much more, carefully. Now, let me ask the issue of how much do we spend. There is a separate slide on that which I'll come to. If you are looking at the total expenditure, you will see that healthcare expenditures right from 1991 was varying from 1.2 to 1.4%. Now, here you see the per capita expenditure for the year 2014-15. 2014-15, there is no data infirmity as such, because by that time that money, they implemented the recommendation of the high-level expert committee of the planning commission, which said that money should not go through the directly implementing agencies, it should go to the state budgets. So that particular part is not this thing. You will see that per capita health expenditure, union and states taken together, you will see the difference that you have Bihar, which has 327 rupees, and you have Kerala 1,244 rupees. You have Gujarat 1,005 rupees, Andhra Pradesh 1,099 rupees. And that's a bit of an aberration, because that is the year where there was a lot of these things, lot of things have happened in that year. But you see the extent of difference. Uttar Pradesh has the lowest, which is 262 rupees. So this is the level of difference that we have in per capita health expenditures. Similarly, in the case of education expenditure. Similarly, in the case of development expenditure as a whole, that is social sector, social and economic services as a whole, and the total expenditure too, you will see that the difference is 1:3 times. Bihar has 8,000, the Uttar Pradesh has 5,800, and Andhra Pradesh that year was an aberration, but let me see, even Kerala has 22,500 rupees. Now, as I mentioned, there are a lot of data infirmities in the health sector. One is because of the lack of comprehensiveness. There is some amount of money the railway spend, some amount of money the defense department spends on health. I mean, these things don't get included in that. Earlier, the labor department used to spend RSPY money. So there is a comparability question. These things have to be put together. The other thing is intertemporal comparity isn't, as I said, the direct transfer to the implementing agencies vitiates the picture. Most of the people say that, health expenditure declined from this year. And then, suddenly it has increased, which is not really the case. And the third one is, as I said, interstate comparisons becomes much more difficult because some of the states have decentralized expenditure through the panchayats, like Kerala, and to a considerable extent Karnataka. And there are others too. But nevertheless, if you look at the thing as a whole, you'll see that total public expenditure, is somewhere, as I said, was stagnant around 1.4 to 1.5% of GDP over a period. Now let me just talk about India's federalism particularly for our foreign friends. We have 250,000 governments in this country. I'll come to that. It's a large and diverse federal country with heavy centripetal bias. I will not go into that. You will see that you have a union government, you have 29 state government, but there are 7 centrally administered territories. In fact, in Canada, you talked about 2 territories. There are 3 territories. So you have 7 centrally administered territories, 2 of them with their own legislatures. Others are purely centrally administered. Pondicherry and Delhi. You have rural local bodies, which is almost 247,257, out of which 585 at the district level, 6,317 at the block level, and 240,000 at the village level. And then you have the urban local bodies, municipal corporations, municipalities, nagar panchayats, etc., etc. Now, so it's a large and diverse federal politics with a very significant centripetal bias. I don't want to go into the details. Indian economy is somewhere about, it's a middle income emerging economy with the PPP income of something like $5,800. Now, the governments vary in size. Now, I mean, at the state level, at the 29 state level itself, you have state governments with 0.6 million to 200 million people. This is the varying, So in the per capita income levels, in Bihar, for example, is 552. It varies up to 2,500, into dollar terms. So I'll avoid much of the talk on fiscal imbalance because I already talked about them. Now let me go into the question of the question of, as I mentioned, rationale for general purpose and specific purpose transfers. I told general purpose transfers are meant to enable the state to provide comparable levels of public services at comparable tax rates if you are able to fully offset the revenue disabilities. In fact, that's the difference again with Canada. What they do is, they identify the tax basis, all the revenue basis in fact, and then work out the effective rate of average effective rate of tax for all the whole country. And in fact, whichever the state which has a lower rate than the base, because base is not actual base, the potential base, whichever gets lower, that is given. But what happened was that, at some point of time, the petroleum prices increased enormously. As a result, even Ontario, which is one of the very industrialized provinces, became eligible for getting money because Alberta had a huge amount of money from oil. So when oil revenues were increased, Ontario also became eligible for getting the money. At that time, they had a workout. I think it's done in the first minister's conference or whatever. They worked out that only half of oil revenue will be taken for equalization purposes. In other words, they have been evolving. the point that I'm trying to make is that they have been evolving, even though it's been done at the Department of Finance level. You know, in fact, there is an interesting, years ago, there used to be a gentleman called Douglas Clerk in the Department of Finance. The trust with the gentleman was so much that he was nicknamed as Mr. Equalization. Anyway, I mean, so general purpose transfers in India, we have a finance commission appointed by the president every year. Article 280 of the Constitution says the president shall appoint a finance commission within 2 years of the commencement of the Constitution, and thereafterwards every 5 years or earlier as may be required. And with the following terms of reference. One, division of taxes that may be made between the union and the states, and the shares of the principles of devolution and the shares of individual states thereof. 2, grants in aid to be given to the states in need of assistance. 3, measures, this was added later, measures to augment the consolidated fund of the states to supplement the resources of the urban and rural local bodies based on the recommendations of the state finance commissions. Now somebody said in the morning, in fact Dr. Paul said in the morning that that money that the finance commission gives to the panchayat should be used for health purposes. People have to realize that this is the constitutional requirement, number one. And number two, the Union Finance Commission job is only to supplement the resources, and it has to be based on the State Finance Commission recommendations, though the State Finance Commissions have not been functioning the way they should, and sort of some general transfers have been made. But at the same time, I don't think the Finance Commission, Union Finance Commission, has the mandate to insist that money should go here or there, because it is only a supplemental nature. And I mean, in fact, there were a number of interesting things happened during the 13th Finance Commission, when they put something like 9 different conditions. They said that this is the total money to be given. Out of this is performance-based condition. These 9 different conditions have been put, and the money will go if those 9 different conditions are met. Those conditions, unfortunately, were to the state government, not to the local governments. You put a condition to the state government saying that you should have a separate, supplement in your budget. You should appoint an ombudsman. You should get these things audited. Now, these conditions were put for the state government so that local government gets the money. In order that the local government become eligible to get money, and state government didn't bother, and the local government didn't get that part of the money. It's as simple as that. So, of course, the 14th Finance Commission did not go into that. It had a different set of conditions given, basically to the state. I will come to that in a little while. So, you have tax devolution, grants to be given, measures to augment the consolidated fund of the states to supplement the resources of the local government, and then the 4th one is any other matter, and in the interest of sound finance. And under this, whatever the union government could not do, was not able to do, it used to refer to the state governments. It used to refer to the finance commission. There are a number of things that happened: public finance management, expenditure efficiency, public sector enterprises, various things. I don't want to get into those details. Now, so this is the situation. Earlier, what used to happen was that in addition to the Finance Commission, from the 4th Finance Commission onwards, the presidential terms of reference, though the Constitution doesn't make that distinction, presidential terms of reference said that the Finance Commission will look at only the non-planned side of the accounts. There is a history to this. The 3rd Finance Commission, that is the time the tension was distinct. Planning Commission was appointed on the cabinet resolution. Finance Commission was a constitutional body. 3rd Finance Commission, while making recommendations, the tension developed, and the majority recommendation was the 75% of the plan requirements should be taken into account in their recommendation. But then the member secretary wrote a note of dissent saying that no, the Finance Commission should not look at the plan side at all. And this is the only time in the history of the Finance Commissions that the Government of India accepted the recommendation of the member secretary and rejected the recommendations of the this thing. And then onwards, Union government became wise. From 4th Finance Commission onwards, they said that the Finance Commission will look at only the non-plan side. In the terms of references itself, they specified that they will only look at the non-plan side. Until the 14th Finance Commission, for the first time, I don't know what happened, whether it is an oversight or deliberate, I don't know. They did not say that we have to look at only the non-plan requirements of the states. The Finance Commission, the 14th Finance Commission. The Finance Commission took this as an opportunity to look at the entire thing holistically, the requirements, so did not make a distinction, and in the process gave the plan side of the grants as well. Took into account the plan, in the assessment, it took into account the plan expenditure requirement as well. I mean, it's a separate thing that, within a few months, they disbanded the Planning Commission. And, in a sense, sort of it became, timely in that sense of the term. What happened in the process is the clarity in the transfer system. Constitutionally, the Finance Commission can give, and some of them have given specific purpose grants. But being a temporary body, is it possible for the Finance Commission to monitor and then supervise and then go into the details of the specific purpose grants? So we said, let us not unnecessarily burden ourselves with this. So the Finance Commission did not go into the specific purpose grant, much as we thought that that's important area. But at the same time, we made a recommendation there. There is a recommendation towards cooperative federalism. There is a chapter where we made a recommendation that these so many specific purpose transfers should be gotten rid of. We should have only a handful of them. They are important, but then should be in important areas. Substantially fund them. Then we also said that the design of the transfer system should be done by the officials of the union, state, and domain experts. Now, of course, nobody has looked at that chapter. So the domain experts or this thing, so the design is done in some, some manner. Some people think and sit and do things. I'll come to that in a little while. Finance Commission, 14th Finance Commission increased the transfers from 32, the tax devolution from 32% to 42%. In fact, all hell broke loose. In fact, somebody said they made a hash of the report. I won't say who. And apparently, when the report, we could not submit the report to the president himself. He was not available that day. And when he came, apparently, he saw the report and then he was shocked. But then he read the report. When he read the report, this is what he told Dr. Reddy, the chairman. He said, after reading the report, I see the logic, he said. So there is a general impression even today that these people have really been overly generous. Now let us go into the numbers. That's important. As I mentioned, we have taken into account not just the non-plan but also the plan. The Planning Commission's Gargill formula grants constituted 5.2% of the divisible pool. When I say tax devolution, it is from the divisible pool. So 32 plus 5.2, 5.5 becomes 37.5. And the Finance Commission desisted from giving any other, discretionary grant. You had forest development grant, you had some grants for judiciary, some grants for health, some lot of spreading around. Not only that, 13th Finance Commission has gone about giving some grants very interestingly. People have not read this. 100 crores for a medical college in Haryana, 50 crores for constructing governor's house in Tripura, 150 crores for temple rejuvenation in Tamil Nadu, so about 150 crores for lake rejuvenation in Karnataka, and the like. 14th Finance Commission said we don't have the expertise to do this. So all the other grants were stopped except the grants for tax devolution, general purpose, for budget support, and the third one is local body grant, and the fourth one is for disaster relief. Besides this, nothing else was given. The saving on that account was somewhere about 2.5% of the divisible pool. So actually comparison, 1.5%, yeah. Comparison should be between 39% and 42% and not 42% per se. Now, it's a different thing for, the commission was overly generous for the panchayats because we thought that the third level needed much more. And we said that the money at the panchayat level, money should be given only to the gram panchayats because the service delivery at the gram panchayat level, because our job is supplementary. And let the district and the block level panchayat should be taken care of by this thing. And again, the formula for distribution is deviation from the highest income state, that's the revenue disability, that is 50%, population was given 27.5%. Now, in that, there was some distinction we made, because in all these terms of reference, you are required to use 1991 population. So there was also, in the term of reference, any demographic change should be taken into account. So we split it. So I don't want to go into the details of that. And 15% weighted to area, 7.5% weighted to forest area. Basically, this is the way we did. Forest area, basically revenue disability as well as the cost disability. Both ways this was. Now, so I'll not go into that, but then if you see the per capita transfers and expenditures in the states, now in the horizontal axis I say per capita income, you'll see the per capita transfers decline as the per capita income increases from this thing, but then you see the per capita expenditures, even after the transfers are given, per capita expenditures are much higher in states with higher per capita incomes. Okay, now I've already spoken about this. Now when we did, there was another interesting thing that happened. One is, I told you the rationale for 42%. We did a very detailed analysis of the central government expenditures in terms of union, state and concurrent subjects. We found that between 2002 and 5 and 2005 and 11, the union government spending on the state list increased from 14 to 20%. Union government spending on concurrent list increased from 13 to 17%. Now, if the constitution says that this is your job and this is your job, if the union government goes about spending more and more, that means that union government has more money. I mean, if this is a state subject, why don't you let the state do it the way they want to? So that is the sort of a thing that this thing. So obviously the 3% additional thing that I talked about was dictated by this particular logic that this union government should focus on defense, its own, sort of, things related to the union government. We did very, very specifically say that we do leave certain amount of fiscal space for the specific purpose transfers, but then they should be pointed, there will be a substantial, thing that. I mean, all the time, there is this saying that, Finance Commission has taken away our money and then we can't give the transfers. I mean, which is, there's, one of the beautiful things that happens with the Finance Commission is that after they make a recommendation, they go away. Nobody can tell them. And of course, Dr. Reddy had a very interesting point to make. He said, if both the union government and the state government abuse us, I think we have done our job. And that's precisely what happened. So, but in the process, what has happened is that untied transfers got substantially increased. And Finance Commission transfers increased from 58% of the total transfer to 76%. So the 24% of the transfers is the specific. So obviously there is a reduced fiscal space. Now, there is some discussion that goes on, what happened afterwards. There is an interesting study going on at NIPAP. Pinaki Chakravarti is doing that study. I mean, he finds that, on the whole, states taken as a whole, the spending on the social sectors, both health and education, has not declined. After this thing, it's marginally increased. There are some states, as I said, there may be some states which are this thing, but by and overall, the spending, because you see what happens is that we make our conclusions on the basis of budget estimates and revised estimates. You need to wait until the actual numbers come in, if you really want to make that. And that's what, from the latest, this thing, you get the numbers for 2015-16. That's an analysis that's going on there. Now, to the extent that, also as I said, higher transfers, fiscal space has been reduced. There has been a marginal increase, as I mentioned. As I mentioned, it is impossible for the Finance Commission to offset the fiscal disabilities completely, and therefore we need specific purpose transfers, and therefore the discussion on the transfers. I mean, this is how the system has come in. Okay, now what I want to do is, on the specific purpose transfers, you have, I said the maximum objective is to ensure minimum standards of public service in respect of chosen. And you had 147 schemes which were consolidated into 66 in 2013 by a BK Chaturvedi committee. But I mean, we do such a lot of lip service in the system. When you do 66, you have A, B, C, D, E within that. And you don't really give up. I mean, it's a pure politicization, if I may say. And there is a huge bureaucracy in the process that you generate. But in any case, when Finance Commission decided to give 42%, the government of India said, in fact, within this audience, I can say, apparently, the Prime Minister was very upset. And the chairman was called, and then chairman said, we, as a Chief Minister of Gujarat, you asked us to do this. He said, yes, now I am the Prime Minister of the country, how can I manage? Then he said, you have 3 options open to you. Number 1, accept it. Number 2, reject it. And allow the previous Finance Commission recommendation to continue. And in the meantime, you appoint a new Finance Commission and wait until that, you don't have to wait until the 5 years are over. Constitution allows you. Number 3, there was a note of dissent by one of the members which said that you should give 38%. So you take that, whatever you want to, you feel like, but then I think good sense prevailed, and then they accepted the recommendation, but went on blaming the Finance Commission for all the fiscal ills in the system. Now, then they appointed a Niti Aayog committee under the convenorship of the Chief Minister of Madhya Pradesh, which reclassified the centrally sponsored schemes into 3 categories: core of the core, and optional. Now, when these are the 3 categories, core of the core is Narega and such other things. Most of the things are core, and the other one, there are some optional things. And they made a uniform, this is how we do our things, uniform matching ratio. For core of the core, 30% states and the 70% center. For the core, it is 40-60, and for the optional, it is 50-50. Now, there are 28 schemes, but then if you look at 5 schemes, they constitute almost 66%, but then actually 3 schemes constitute about 48%. That means Sarva Shiksha Abhiyan, National Health Mission, and Narega. Now let me come to the National Health Mission. I mean, that's the one which we are discussing about things. National Health Mission the objective is to provide accessible, affordable, accountable, effective, and quality to health care. This is what the website says. Please, I'm quoting there. Accessible, affordable, accountable, effective, and quality to health care. And it was started in National Rural Health Mission in 2006. And 12th plan document gave a broad framework for it. the objectives are, again I take it from the thing, safeguard health of the poor, vulnerable and disadvantaged, strengthen public health system as a basis for universal access and social protection against rising costs, build an environment of trust between people and health service providers, empower the committees, empower the communities to become active participants in attaining the highest possible levels of health, improve efficiency and objective and of the use of resources. Very noble objectives. I mean, I don't want to go into the details of that, but I just wanted to state the objectives that are stated. These are supposed to be achieved by building an integrated network of primary, secondary and tertiary healthcare facilities and achieve intersectoral coordination to access food security, nutrition, safe drinking water and sanitation, education and female and children, etc., etc., etc. I mean, these are the things that are given. It has 5 components. One is the NRHM. Within the NRHM, there are 2 components. Reproduction, reproductive, maternal, newborn, child and adolescent care. Health system strengthening. Second one is health system strengthening, infrastructure, human resources, program management and transport. This is done NRHM. Then you have National Urban Health Mission. Then you have control of communicable diseases, then control of non-communicable diseases and infrastructure maintenance. I am just talking about the details, and I am sure Sujata will tell more about it because she is you know, it was fully centrally funded when it started in 2006, but later in the 11th plan they made it 85-15, that means 85% for the center and 15% by the states. And 12th plan up to 2014-15 it was 75-25. After the Finance Commission report came it is 60-40. I mean that's the history. How does it get determined? Because before I go into the evaluation I want to talk about this. One is the ministry, I'm sure this is something which you know very well. Ministry works out an envelope and sends it to different states. Now, this is based on area, population weighted with socio-economic backwardness, and health lags, and 10% given to states that demonstrate the ability to spend efficiently. And then, of course, the weightage to the population is, what is that? EAG states 1.3. EAG large states, EAG small states 1.5, and then some broad sort of thing. I have not been able to understand how they have been able to work out the health lags. I mean that I have no idea. Now the problem with this particular thing is that the problem with this this thing is that you have too many objectives that have been put in place. If you want, in fact, if you want to ensure a minimum standard of public service, you should define what you want to do, and you should basically cost that, and you should basically work out on the basis of that. And if you had said that, look, basic infrastructure in terms of this, you want to put everything there, non-communicable disease, this thing. As a result, what happens is that in fact, Niti Aayog report says that there were 2,000 budget heads for health. Now, imagine the situation where you have to monitor, and you are basically, first of all, you have 28 schemes where you spend resources thinly. Within that, you segment the resources for different, different activities. And then, the amount of compliance requirements that the states have to do, then you come up and say that states are not complying, so we can't give the money. Utilization certificate is not given. Now, PIP is prepared by the states based on resource and communicated to the national NPCC, National Planning Coordination Committee or whatever, and they approve the thing, the money is given, the states spend, they follow the compliance. I mean, this is the, in other words, if your objective is, to ensure minimum standards, you have to define whichever way you want to, and you have to find out who is below that standard, and then basically work out a system to give the transfers that way. There is further thing. Now, when the money is given, obviously you said that the state government should put 40%. State government will put 40%, but they will cut down somewhere else. The health is a much broader area. So, when, in the design you have got to show, to ensure that there is a net increase after the transfers are given, which basically implies that what is the state's own spending on health, and what would be the, if you apply a growth rate, past growth rate, what should be its expenditure. Now on top of it, so one of the conditions basically there should be to say that, look, that much of expenditure you should definitely do it from your budget. You should not simply substitute what we give. So there is a bit of a substitution. My regression show that substitution is to the tune of something like 36%, 36 paise per every rupee that is given, average. I mean, this is sort of a regression study that was done. Now, what are the major shortcomings of this? There is lack of clarity of purpose, too many objectives, several activities across sectors, too much of a bureaucracy, micromanagement of lack of trust, and difficulty in fixing accountability. 2, allocation is not according to shortfall in services. It's an incremental approach, to preparing PIPs and the approval process. Actual release, there is the third thing. In between, there is a budget cut. And when the budget cut happens, the states would have prepared their plans, then suddenly they find that they don't get that money. So actual release is much lower than the allocation. And the difference between release and this thing is related to per capita GSDP. That means the states which are better off are able to get, get much higher proportion of their allocation than the states which are worse off. Now, compliance requirements are too many. One of the important questions that I was asking is, see, in 1974, Martin Feldstein wrote an interesting article in the context of United States in American Economic Review, where he said that when you have large differences in the service levels, you could have a varying matching ratios. We already have varying matching ratio between special category states and general category states. Why not categorize states into high health status states, medium health status states, low health status states, and vary the matching ratios, something like, sort of 40%, 30%, 20%. I mean, why do you want to have Kerala, which has substantially improved, also paying 40% as compared to Bihar or Uttar Pradesh, which paying, 40%. These are the states where their fiscal disabilities are not fully redressed, and still they have to pay 40% for that. So many of them are not able to pay and not utilize the transfers. Then you call them bad fellows. So possibly, again, you may have to think of a multi-year budget. You have to think of developing the capacity of these states to deliver, because the larger proportion of the poor children are there. I mean, they have to be educated. They have to be provided with health, because that's a capital that you give. You can't go in to do any other thing. Okay. Now, but if you look at all transfers taken together, general and specific purpose, you will see this is the type of, and you convert them into indexes. Index of own revenues, with average as 100. An index of revenue accruals after transfers are given. You will see that the blue line is the index of own revenues. That means with the increase in per capita income, it goes. There is equalization that happens. And much of this equalization happens because of the finance commission transfers. I mean, in fact, there are regressions which show that the finance commission transfers is the only transfer which has a progressive element in it. And specific purpose transfers. In fact, National Health Mission transfers, in fact, those of you who want to look at this very carefully, details, in the Niti Aayog website there is a paper which I was forced to write on the intergovernmental transfers, where I make a very detailed analysis of Sarva Shiksha Abhiyan, National Health Mission and this thing. There is a graph which was shown by Dr. Paul in the morning, which basically shows that per capita, National Health Mission, the transfers are not related to per capita income at all. So, you do get this type of a thing. There is equalization, but still, the revenue, ultimate revenue received by the high income states is much higher. Now, if you look at per capita expenditures on health, you'll see the sharp increase, with per capita income on the right hand side. The other one is on education, this one is on health. So anyway, I've already spoken about many of the problems. We do not need 28 specific purpose transfers if you want to give substantially higher amount of money. In fact, in Canada, they have 3 major specific purpose transfers, one for post-secondary education, the health, and there was a third one on social security. But then we want to, you see, the union government wants to say that, look, tell the people in the state that, look, I am doing your work. Your state is not doing. Basically, that's a sort of a thing. Whichever is the union government. I have no, I am not talking about any particular party in power. So, there is, as I said, I don't want to repeat the thing. Fiscal transfers to states are critical in view of the wide difference in fiscal capacity. General purpose transfers are not able to offset the fiscal disabilities. There are political difficulties in doing them. Finance Commission mechanism has been most equalizing, but then it cannot completely offset the disabilities. National Health Mission transfers, in my view, requires a lot more of reform, lot more of thinking, and I do hope that Niti Aayog will, since Dr. Paul has already looked at it, and he said that it was revealing, he said, and the analysis. I do hope they will make it, ensure that much more, this is not the only thing. There is an implementation issue. The states have to do a lot more of things for implementation. I have not gone. And then possibly you will have to involve the panchayats at the, as we go along, rather than implementing agencies. They are not designed to ensure service levels. There is uncertainty about fund allocation. Uniform matching ratio puts low-income states at a disadvantage. There are problems of implementation as well. Per capita expenditure in health, education and healthcare are positively related. This is all that I want to say with regard to intergovernmental transfers. Thank you.
I think it was you really covered the whole universe of it. And one point I think very specifically that there are limitations to equalizations. That disability cannot really, and I'll give you a specific example from my own case. In Goa, we used to give, I don't know what they do now, grants to village panchayats based on the amounts they collected as house tax. And we had them in 3 categories, 1, 2, and 3. The richer panchayats we gave 50%, the normal panchayats we gave 100, and the poorer panchayats we gave 200%. 200% is a lot of money, right? And so my minister, panchayat minister said, Mr. Sinha, this is too low, you should increase it. I said, how can I increase it? No, you can double it. Then he told me a case of one panchayat near his place. We had done matching grants, everybody, 100%. He said, no, poorer ones you give double it. He says, fine, but I was objecting like a bureaucrat. The biggest panchayats is to collect, interesting day. Don, can you do it in 2 minutes?
And I don't know if I'll ever get back to this tomorrow because this is...
It's rare that at 7 in the evening you have still 41